meeting last year, you can see how they did a study as to what patients care the most. And when you look at things like appetite loss, diarrhea, fatigue, and symptoms, when you compare ribociclib to abemaciclib, really ribociclib, all these side effects favor the use of ribociclib over the use of abemaciclib. So really a truly tolerated drug. Now, so as you know, ESMO and the ABC does measure what we called the magnitude clinical benefit score. And in the magnitude clinical benefit score, you take into account disease-free survival, and also quality of life. And if you see, the only agent that has a category 5 in the magnitude of clinical benefit score by ESMO is ribociclib. Why is that? Because in the Mona Lisa 7, in the study with premenopausal patients, it showed improvement in quality of life. Now, when you look at first line, ribociclib has a category 4 in the postmenopausal patients, and we will wait to see what happens with abemaciclib. For second line, they're all in the same line, except obviously palbociclib, which did not show improvement in survival. Now, what happens when you have
Dr. Frank, I'm not sure if you hear us, but I think you're not connected, so we can't see you or hear you anymore. Dr. Frank, again, we can't see you or hear your voice. I wish you were still with us if you have any problem in your connection. So I hope to be fixed soon. Thank you.
Yes, sure. Sandra, I think we cannot hear you, most likely because the problem is in your side. The viewing sound.
So for the attendees, thank you for your patience. I guess we will be joining the game with Dr. Franco in a couple of minutes. So thank you for your patience.
Yeah, no, no.
So welcome back, Dr. Franco, and I guess you had a minor issue with your connection, so the floor is yours again.
Okay. So, so you lost but you were able to hear the whole talk, right?
Yes, but I appreciate if you could share the slides again, one more time, because we cannot see it.
Lynn, can you help me? You couldn't see me at any point. You couldn't see the talk?
No, we can see you, but we cannot see your slides. So are you able to share?
I think the last slide was about the role of chemotherapy before the
So can someone, you were not able to see my slides throughout the presentation or just the
No,
last?
No, we enjoyed viewing your slides all through your presentation, but at the moment we cannot see your slides. I'm not sure if you
Oh,
shared.
no, I took them off. Yeah, no, I
Great.
stopped sharing the slides.
Okay, great.
Okay. So
We
we're,
have one more talk.
You want me to share them again?
I'm not sure, we can, I guess we were up to the last few slides. I'm not sure if you're done or not with your slides, but we can go to the questions if you completed your presentation. I'm not sure
Let me,
at what point we lost the connection.
okay, okay. Maybe if you want me, I can share them again.
So, yeah, if you can go back to the slide where you talked about the indications of chemotherapy.
Sure.
Breast cancer, then we can
Who
go.
needs to- The organizer needs to let me share again. You guys have to give me permission to share the
So,
slides.
Dr. Franco, just for the sake of time, I'm very sorry, but can we go to the question part?
Okay.
Okay, so for for the rest of the attendees, I would like to thank you all for your patience, and I guess we can receive your questions. One question.
Thank you for your talk.
So, Dr. Marwan,
Thank you for your talk. I would like to know if there is any data regarding patients who fail ribociclib down the road, they don't get to the 5-year survival. If there is any specific genetic alterations, like BAL2 or PIK3, or has anybody looked into that? And then, 5 years, what's their genetic profile?
Could you repeat your question? I'm having trouble with probably the volume. Can you just repeat it or someone repeat it for me? I don't think I heard your question completely. So could you repeat the question, please? I'm sorry. I cannot hear anyone.
are you able to hear us now? No?
I can hear you with a lot of echo, but yes, I can hear you.
Maybe we will move to Dr.
Dr. Franco.
I can hear you. Yes.
Yes, okay. Why some patients fail on ribo while patients continue to 5 years and over 5 years? Is there any specific genomic profile aberrations during the trip on ribo, during why they fail, and at the end of 5 years, what's the genetic profile? If there is a mutation in PAL2,
Okay.
PIK3, and did anybody looked into that? Why the failure?
Okay. Okay. Okay, so we know that we are not curing patients, right? And I think your question goes along as to why do some patients do as good as more than 5 years, and why some patients don't. And there's been a lot of attempts at trying to understand that. A lot of biomarker studies done on these patients, particularly with ribociclib, also palbociclib, because we do have tissue. Probably the one studies where not a lot of correlative studies have been done is with abemaciclib. But what do we know with ribociclib? Because there's 3 trials. Probably the Mona Lisa effort is the largest effort with all 3 drugs. So we have a lot of patients. So what do we know? In terms of that PIK3CA does not matter. The drugs respond as well for PIK3CA mutant patients as with the ones that don't. But there's an issue. There was a study done by Alex Pratt that looked into all patients in the Mona Lisa trials across all clinical trials, and they did the breast tumor subtype by PAM50, right? So that study that divides patients into luminal A, luminal type B, basal type, and then HER2, right? So what do we know? That for patients with both luminal A and luminal B, there's a very, very good response. There's also an exquisite response for patients who are in the HER2 enriched subgroup. So when you compare the benefit of, and that's about a 17% of patients in that particular study. When you compare they did the same for palbociclib, and there was no benefit of palbociclib in the HER2 enriched subgroup. There was a huge benefit for ribociclib in the HER2 enriched subgroup. So that might account for some of the differences between the responses to palbociclib or ribociclib. Now, the other issue, and this was a very important issue, was there was a 3% amount of patients in the in all those studies that even though they had phenotypically estrogen receptor positive tumor, they were basal type breast cancer. And when they looked at that subgroup for the basal type breast cancer, there was no benefit of ribociclib. That actually led to a clinical trial in which there, and it's to my knowledge, probably one of the only clinical trials that's comparing head to head palbociclib and ribociclib. What they're doing is they're looking into the intrinsic subtype with this test. And if the patient is HER2 enriched, it's randomized to either ribociclib or palbociclib. If the patient has basal disease, patient goes to chemotherapy directly, because that might be a subgroup that does not benefit from either hormone therapy or hormone therapy with this treatment, which is expensive, right? And we do not want to waste the treatment on that. Other than that, we have no biomarker that tells us that the patient's going to do well or it's not. And that is why the only biomarker up to today remains the estrogen receptor status, right? So if the patient has estrogen receptor positive disease, the treatment of choice is the ICDK4/6, in this case, ribociclib with hormone therapy. There's no other biomarkers that's going to tell us whether the patient's going to do well or not.
But the locally advanced breast cancer, where we have T4 lesion or T4B lesion, where we have muscle involvement or skin involvement, do you advocate giving chemotherapy or what's your choice for this patient?
So if I'm understanding your question correctly, okay. So if
for a patient who has
I'm understanding is if you have a patient
with locally advanced breast cancer, where we have involvement by T4 lesion or T4 even B lesion, do you advocate giving chemotherapy For sure, shall we go for CD4K inhibitors?
I think that's a very good question because I think patients with locally advanced breast cancer were included in these clinical trials. But the way I see it, doctor, is if I think that I can cure the patient, right? If I think that I can continue the control with both surgery and radiation therapy, I go for curative intent, right? So in my mind, I will give chemotherapy to the patient to go take the patient then to curative surgery and curative radiation therapy. If the extent of the disease is such that I know that I won't be able to control the disease, that is a contralateral lymph node, for example, not an ipsilateral lymph node, extent of the disease in which I cannot take the patient to surgery, I probably won't give chemotherapy. But if my intention is to give a curative treatment and to go with all the standard of care for a patient that will need chemotherapy, then surgery, then radiation therapy, then hormone therapy, I will go for the curative treatment. And that's a situation in which you will decide once you have the patient up front, once you've discussed it in multidisciplinary meetings in which you have the surgeon who tells you, oh yes, if you downstage that patient, I'll take that patient to surgery because I can do it. Like I can find a flap to cover the big defect, whatever the situation is at that time. But those are situations that are truly important, right? And they have to be discussed in a multidisciplinary meeting where everyone gives their opinion and you will decide to do what's best for the patient. I've had cases in which the extent of the disease is so big that a surgeon tells me I'll never be able to operate on that patient. So maybe at that point, you are better off using ICDK4/6, ribociclib, and hormone therapy. And then if things change along the line, then you can attempt to cure the patient. But, I actually participated in Mona Lisa 7. So I have patients that were on ribociclib, Femara, and LHRH agonist. And my longest patient lasted for 8 years on treatment. And last year she had a recurrence, right? So I was very happy. She had a complete response of her liver lesions, of her bone lesions. She was 29 at time of diagnosis. 8 years later, she recurred. And now we're giving her all other types of treatment. And so I was, that you are not curing these patients.
Thank you very much.
Thank you very much, Dr. Franco. So we really enjoyed your comprehensive talk. Just for the sake of time, I'm sure that some of my colleagues have more questions, but I believe that we need to end the session by now to give time for the next one. Thank you again, Dr. Franco, for taking the effort of presenting your session very early in the morning, and I wish you to enjoy the rest of your day.
Thank you. Thank you so much for inviting me. Hopefully we can see each other soon in person. Thanks.
بس نفس الصورة علينا هون وين هون بس الصورة بتطلع صورة Hello, everybody. Thank you for being here with us today. It's my pleasure to introduce Dr. Massimo Briccio. He's an associate professor at Sapienza University of Rome. He's head of the DH unit. He's author and co-author of many publications focusing on the treatment of acute and chronic myeloid leukemias and MDS. He's editor-in-chief of the prestigious Analysis of Hematology journal, and he will talk today about CML management beyond first-line therapy. Also, I would like to thank Novartis for their generous support for this symposium and GSH. So welcome, Dr. Freshin.
Thank you so much. Can you hear me?
Yes, we can hear you.
Thank you. Thank you so much for your kind invitation. So I try to share my presentation. Can you see the presentation?
Yes, we can see.
Yes, we can see you, yes.
Okay.
Yeah, we can see your presentation and you can start, yes.
Thank you. Thank you so much. So this presentation is about the management of chronic myeloid leukemia behind first line. And we will review together an important, I believe, trial that allowed the possible prescription of a new tyrosine kinase inhibitors called asciminib. So before to see this important data, a brief summary about this disease that, as you know, is a very rare disease, a clonal malignant myeloid neoplasia caused by a balanced translocation between two chromosomes, 9 and 22. The juxtaposition of two oncogene BCR on chromosome 22 and ABL on chromosome 9 show the resulting fusion protein that is BCR-ABL, that, as you know, function as an oncogenic tyrosine kinase and is responsible for the leukemigenic process of this disease, and responsible also of the baseline characteristics. So in particular, increases cell survival, motility, and proliferation, because act on different signaling pathways such as RAS or AKT. So about the diagnostic workup, usually this disease presenting with a leukocytosis. So the first sign is the identification of peripheral blood analysis, morphological analysis of immature blood cells, such as myelocytes and promyelocytes. But the confirmation should be based on bone marrow analysis through the cytogenetics with chromosome banding analysis to identify the translocation 922, and then in real time qualitative analysis at baseline, and then quantitative PCR, so polymerase chain reaction, during the treatment and during the monitoring by the international scale. So the therapy and the treatment of this disease drastically change the outcome of our patients from 2000 with the introduction of the first tyrosine kinase inhibitor, imatinib. Then second, third generation, but now we talk about fourth generation TKI, so asciminib, mentioned it before, because act for the first time with a completely different mechanism of action. So although the outstanding results that we achieved with the tyrosine kinase inhibitor, some important unmet needs remain. In particular, we have to talk about the treatment goals that we have to reach in chronic phase CML, then the need for new treatment options and the unmet needs. For the subset of patients with a T315I mutation, but also we have to refer to quality of life and economic burden for the later line CML. So about the treatment goals in chronic phase CML from first line, but also after the first line in second or later line, from last years, we introduced the concept of the so-called patient-centered medicine approach. So we have to try to choose the best treatment at baseline, not only to achieve the important milestones, such as, for example, complete cytogenetic response, early molecular response, and then deep molecular response in order to prevent disease progression, improve survival and quality of life, but also the best choice to reach a possible discontinuation of the treatment over time, the so-called treatment-free remission, in order also to minimize the treatment-related toxicity, such as the off-target effects. So we choose the best line and the best approach according to age, comorbidities, and concomitant drugs for the possible intolerance, but also in terms of prognostic scores, and the most used in clinical practice is now the UDOS long-term survival score. From the Swedish registry, we know an important information that after the introduction of imatinib as the first treatment, we improved the overall survival. And this is, I believe, an important communication at baseline with our patients that is now near to that of general population. So we reduced the very low rate of CML-related deaths. And for this reason, it's very important to monitor molecular analysis during treatment, according also to the international guidelines, such as the American, the US NCCN, or the European Leukemia Net recommendation that show how we can and we must perform quantitative analysis every 3 months, even if the major molecular response, so the ratio equal to 0.1% is achieved and confirmed. Although these guidelines, most of the countries not always followed this type of suggestion, and UDOS in collaboration also with Novartis and the European Leukemia Net tried to standardize and implemented the molecular testing all over the world. And for example, in Italy, there's a program by the Gruppo Italiano Malattie Hematologiche dell'Adulto, GMEMA, together with Novartis and called LabNet, that standardized the majority of molecular labs all over the nation. And with the standardization of this technique, and in particular, we can refer to an international scale in percentage, we need also new definition of molecular responses, and in particular of the so-called DMR, so deep molecular responses. HEMA4, HEMA4.5 means that we reach from the baseline a reduction of 4 or 4.5 reduction of the molecular burden of disease. These two types of molecular responses and categories now correlated with a lower risk of progression and death, but in particular are now the sustained molecular responses as a criterion to attempt the discontinuation over time. For the first time, the German group in a large cohort of patients treated with imatinib inside a German study 4 trial showed that if we reach a sustained EMA 4.5, we have also an increased overall survival. This is the first important responses and the first important information about molecular responses associated with overall survival, but not confirmed over time with different groups that are indeed all agree that if we reach the first step, so the molecular analysis at 3 months and the achievement of the so-called early molecular responses, so a molecular analysis that show a ratio equal or less than 10%, we have an increased overall survival and an increased progression-free survival in the long term. So for this reason, we followed the European Leukemia Net guidelines and recommendation that, as you see, stratify the patient according to 3 different categories: optimal, warning, and failure. Failure, for example, means that at 12 months, patients that did not achieve less than 1% of ratio need to switch rapidly to another line of treatment in order to prevent disease progression. But although these important results, some important unmet needs remain in third line. In particular, the number of patients that failed the previous lines of therapy from some international registries, such as, for example, the UDOS or the Italian AIFA monitoring registry, we know that if we started with imatinib, about 30% of patients can experience resistance. If we treated the patients with a second generation TKIs frontline, about 15 to 20% of patients leave the treatment for a failure. With a second generation TKIs after this failure in second line, we rescued about 40 to 45% of patients, less than 30% if we started with a third line. So an unmet need is that the sequential TKI treatment from a second generation to another second generation TKIs always has been associated with worse response rate. And all the responses that we know are from sponsored clinical trial for each drug, as you see, nilotinib, bosutinib, or dasatinib, sponsored trial that are not comparable, because based on the specific safety profile of each drug. In second line, with this type of drugs, we can rescue, as you see in terms of MMR, from 28 to 37% of patients. And another most important point is that the sequential TKI treatment is always associated also with a decreased overall survival. And this was explained also in some retrospective real-life evidence paper that showed how if we treated after failure of a second-generation TKIs in second line with a third line, but with another second-generation TKIs, the overall survival is reduced to less than 80%. The other important point is that sequential TKI treatment in third line, if not based on the mutational screening, may allow the emergence of mutant clones, and in particular of the most terrible, I believe, mutations for clinicians that follow CML patients, that is the T315I, or the so-called gatekeeper mutations, because not only one drug until now is possible to prescribe all over the world. In this slide, as you see, when we talk is animated with important dendrograms is another most important point. So all the available TKIs are ATP binders, so have the similar mechanism of action and are not selective only on ABL, but can act also in a different tyrosine kinase receptors, and these are responsible of the so-called off-target effects in the long term. It has been estimated that about 20% of patients in the long term leave the treatment for the occurrence of important side effects, in particular cardiovascular and pleuropulmonary side effects. And intolerance is the main reason for discontinuation of CML treatment. If we look at the sponsored trial in third line in particular, or in the T315I setting, about 30 to 40% of patients, unfortunately, leave the treatment for occurrence of life-threatening, I believe in some cases, side effects. In T315I mutated settings, now we can also have another drug called asciminib that was tested in the phase 1 trial, and at the dose of 200 mg BID can be a possible option. For the T315I mutated patients, has been estimated that after imatinib failure, the frequency ranged between 3 and 15% is higher for patients that failed a second-generation TKIs. The Chinese group can also prescribe for this setting olverembatinib. Is a new drug, but only for the Chinese population in the setting of T315I, that has been also associated to an increased toxicity, in particular thrombocytopenia, and again, cardiovascular side effects, because it is based on the scaffold of ponatinib. For T315I setting, we have to remember that this setting of patients is always associated with a lower overall survival and an increased progression to advanced phases of disease as compared to all the other patients with non-T315I mutations after resistance, after failure of a second-generation TKIs. And last but not least, I believe the most important point of the quality of life and the economic burden in later lines. Quality of life in several reports have been reported in later line CML in chronic phase, similar to quality of life of patients in advanced phases of disease, in particular in accelerated or blast phases. So in terms of physical and emotional domains of different reports and different questionnaires that have been used in this type of work, even in real-world evidence. The other one is that we increase the cost, and the average total cost in the year after treatment failure increased by line of therapy. We have also to consider all the other medical service costs, in particular, for example, the continuous access to the emergency department, and the associate cost higher for a patient that receives a bone marrow transplant. So for this reason, has been created this type of TKI that is selective on ABL, because it was tested on more than 500 cell lines. It seems that is selective only on ABL, so is not associated with the off-target effects, and for the first time change completely the mechanism of action. For this reason, it's called STAMP inhibitor, from specifically target the myristoyl pocket. As you see from the slide, it connected to another domain of the ABL kinase and not on the ATP side as all the other available TKIs. So created also to be combined with all the other TKIs as tested, for example, in combination with all the other second generation or with imatinib in the phase 1 trial. So FDA and European EMA approved this drug in third line after the results of this phase 3 randomized trial that tested asciminib at the suggested dose for non-T315I mutated patients of 40 mg BID versus bosutinib in third line. So the reason of choice of bosutinib is because it's the unique inhibitor in which we have trial that tested the drug in third line. So the strong rationale is based on the mechanism of action of this drug. In the normality, ABL is auto-inhibited by the existence of a myristoyl N-terminal peptide that acts on the specific site of the kinase, inducing the inactive conformation. When the translocation 922 occurred, this peptide was lost, unfortunately, for the juxtaposition of BCR and for the creation of the BCR-able oncogenic protein. So asciminib mimics the role of this peptide because it acts on the vacant binding site, restoring the inactive conformation. So the strong hypothesis and the rationale of this drug is that was tested for the first time with a completely different mechanism of action versus another second generation TKIs, such as bosutinib. The ASSEMBLE trial is a randomized 2-to-1 trial that enrolled 233 deeply resistant patients after 2 previous lines of therapy that were randomized to asciminib 40 mg BID versus bosutinib 500 mg once a day. We have now a long-term follow-up presented recently at the last EHA meeting and with a sub-analysis at the ASH meeting for the survival and follow-up at 96 weeks. So the criteria, the inclusion criteria were allowed to enter only patients after 2 previous lines of therapy, excluding T315I or V299L mutations resistant to both, in particular to bosutinib. The primary endpoint is the MMR rate at week 24, but we have now data at 96 weeks of follow-up, even regarding the specific safety of this drug. In terms of baseline characteristics of female prevalence in the bosutinib arm, the number of patients that receive a third line is very similar, with a slightly difference between the asciminib and bosutinib arm, in particular for the previous number of patients that experienced the lack of efficacy in the bosutinib arm as compared to the lack of tolerability in the asciminib arm. But if you look at the table, similar number of patients entered the trial in both arms, with more than 10% of ratio with a deeply resistance and with the similar number of mutations. About the number of patients and the patient disposition, at the last follow-up, 71% of patients treated with bosutinib leave the treatment as compared to 38% of asciminib, and the previous the reason for leave the treatment is, in most of the cases, the lack of efficacy with bosutinib, as you see, or adverse events. So the median duration of exposure is longer with asciminib arm, 43 weeks as compared to 29 with bosutinib, and the median dose intensity is near to that provided in the trial for asciminib. Indeed, most of the patients treated with bosutinib required a dose reduction in line with the data reported in the previous phase 4 trial called Beyond for bosutinib, in which, as you know, started with 500, but the majority of patients and the median dose intensity is only 300 milligrams, because more than 79% of patients required a dose reduction due to the adverse events. The primary endpoint was achieved in favor of asciminib, as you see at 24 weeks, with a delta of 12.2%, even when the analysis was adjusted in terms of major cytogenetic response at baseline. At 96 weeks of follow-up, and these are the analyses at week 96, there's a double of patients that achieve this type of response with asciminib as compared to bosutinib. And in particular, also the number of patients that achieve less or equal to 1% is in favor of asciminib arm. Regardless of the type of previous baseline characteristics, so even in patients heavily pretreated, this analysis was performed at week 24, and now at week 96 is more evident that regardless of the previous lines of therapy, so even in patients that received before this trial 4 or 5 lines of therapy, the responses achieved are in favor of asciminib. If we look at the cumulative incidence indeed of MMR, by week 24 was 25 as compared to 12%, at 96 weeks of follow-up, 41 as compared to 23% in the bosutinib arm. And we have also the information of patients that at 96 weeks of follow-up had less or equal to 1%, again by the analysis by week 96, 54% as compared to 34%. And a recent sub-analysis presented at the last ASH meeting showed that the responses deepen over time. So even in patients that did not achieve less than 1% at week 24, then we have a reduction of molecular burden during the treatment. Even in terms of CCYR rate, a difference in favor of asciminib with a delta of 17%, and at week 24, even a number of patients that achieve immediately, so very fast, deep molecular response, so MR4 and MR4.5. In terms of safety, the more common side effects recorded in the asciminib arm were thrombocytopenia and neutropenia. Similar number of patients that experienced overall side effects. Indeed, in the bosutinib arm, the well-known safety profile with diarrhea, nausea, and increased transaminases level. So if we look at the number of patients that experienced side effects, as you see, overall 89.7% in the asciminib arm as compared to 96%, but with a reduced number of grade 3 events. But 2 patients experienced fatal adverse events in the asciminib arm and 1 in the bosutinib arm, so similar. But the number of patients that required discontinuation due to the adverse events, dose adjustment or interruption or additional therapy due to the adverse events are all higher in the bosutinib arm as compared to the asciminib arm. About the patients that experience indeed arterial occlusive events, 5 overall in the asciminib, 1 in the bosutinib. Remember that are heavily pretreated patients with nilotinib, dasatinib, and ponatinib, so previously exposed to different drugs and different toxicity of these drugs. About the cardiovascular side effects recorded then that lead to fatal event, the one patient that experienced ischemic stroke that was fatal in the asciminib arm is a patient that was affected by arterial hypertension and left ventricular hypertrophy that was treated before with nilotinib and dasatinib, and that presented a baseline ECG abnormalities. The other one, indeed, is a patient with arterial embolism, again affected by arterial hypertension, previously treated with other 3 drugs, but the event occurred after the discontinuation of asciminib, and the patients are indeed under ponatinib treatment. So this trial show how, for the first time, there's a comparison of responses rate in 2 drugs. One is a second generation and one with a completely different mechanism of action that demonstrated significant and clinically meaningful superior efficacy. So probably opened the way for this drug as a possible treatment option in later line CML in heavily pretreated patients and heavily patients with a high comorbidity burden. For this reason, I want to present finally the MAP program, so the Managed Access Program, the preliminary data of the Italian group, presented at the last HIA meeting and then as a plenary session in the Italian Society of Hematology. The next update will be presented at the next HIA meeting. We reached 77 patients. The first 34 patients that receive asciminib in 3rd or later line between April 2019 and October 2021. So 2 points of observation, 3 months and at the last follow-up, and the safety indeed was extracted from the Argus database, that is a sponsored database reporting adverse events related to Novartis compounds. So about the characteristics of patients, the median age is 63 years, 10 patients with mutations, 5 of them with T315I, heavily pretreated because half of them received 4 or more lines of therapy before. 62% were entered this managed access program for resistance. And as you see, half of the patients that are heavily comorbidity burden because were affected of 3 or more comorbidities, in particular cardiovascular side effects. 59% of them received previously ponatinib, and only 7 patients have to decrease the dose. 25 indeed not change the dose. The dose suggested is 40 mg BID. 4 patients with T315I were treated with 200 mg BID as suggested. Faster responses after 3 months and then maintained and achieved at the last follow-up, in which 42% of heavily pretreated patients are in MMR and 23.5% in deep molecular response. And a sub-analysis of this data and then was confirmed all over the world by other MAP program, for example, the Russian or the UK also that were presented recently at the ASH meeting, showed that if the patients are ponatinib pretreated, are at disadvantage in terms of responses. As you see at the last follow-up, the ponatinib naive patients achieved 46% on MMR as compared to 23.5% of the ponatinib pretreated. Even in terms of deep molecular response, 36% ponatinib naive as compared to 10% if ponatinib pretreated. I believe that this important information will change the algorithm and the therapeutic scenario in this setting of patients. As to the safety, the more common hematological side effects again is thrombocytopenia, but as you see that only 19% of patients experienced overall toxicity and hematological toxicity. Non-hematological toxicity, 80%, but the majority as a grade 1. The most common, the increased reversible amylase and lipase that required a specific monitoring during treatment. No new safety events as compared to that observed in the sponsored clinical trial. And with this slide, I would like to thank you for your kind attention.
Thank you, Dr. Bashir, for this interesting talk and update on CML treatment. Is there any question from the audience? I have a question about these plethora of treatments now available for CML patients. As you know, that there's many patients who progressed or who are resistant to first-line therapy. Probably they will continue to progress on second line and third line, and they will need multiple treatments. So if a patient has a donor for bone marrow transplant and he's young, would you consider transplant in the second line setting, or you just keep giving the second and third line drugs?
So in my center, and I work in academic center, all the patients with previous resistance now are treated with asciminib because we participated in the phase 1 trial from 2013. So none of these patients perform bone marrow transplant. I believe that if we can prove before to plan a bone marrow transplant, a pharmacological intervention is better if we consider that usually patients with comorbidities, no? And the median age is 60 to 65 years. So I follow the European Leukemia Net guidelines as regard to bone marrow transplant suggestions. So for patients that are not in response or resistance after 3 or 4 lines of therapy or have important mutations that require an intensification of treatment.
Thank you. Any other question from the audience? It seems that everything is clear, and thank you, Dr. Brescia.
Thank you
for
so
being
much.
with us today, and hope you have a good day. Thank you.
Thank you. Thank you. Thank you.
لو عندك الستة يلا تبدأ طالع.
Bismillah. I'm Abdul Abadi. I'm sitting for Dr. Ayman Hamloush, who had for medical reasons could not attend the session. It's my great pleasure to present Dr. Mahmoud Fadl, who's a senior consultant at the Royal Medical Services, Pediatric Hematology Oncology, and he chairs the Division of Hematology Oncology and Medical Services. He has vast experience in bone marrow transplant as well as various hematological diseases behind and malignant. And he's going to talk today about the updates in Hemophilia B, which is something sponsored by Pfizer, to whom I would really like to say thank you, and thank you to Ryan for attending this activity.
Thank you, Dr. Abdullah, for your kind introduction. And thank you for the GSH and Pfizer for the kind invitation. And it's my honor to be here with you today. And we will talk lightly about the updates in hemophilia B, which is actually less touched by other hematologists because it is less common compared to the hemophilia A. First, we will talk about hemophilia. Hemophilia is a bleeding disorder that is associated with low level of procoagulant, either one of the factors, either factor 8 or factor 9, and rarely other factors. And when we talk about hemophilia, most likely we are talking about congenital hemophilias, because you in the adult age group encounter some cases regarding the acquired hemophilia, which are rarely seen in our facility in the pediatric age group. And actually for congenital hemophilia, it is not a must to be inherited, and it can be even sporadic hemophilia, which means that it occurs after de novo or a new or spontaneous type of mutation. The most commonly encountered hemophilia that we are dealing with is hemophilia A, and it constitutes more than 80% of all hemophilias, while for the hemophilia B, it constitutes nearly 1/5 of all hemophilias. And the most characteristic type of bleeding actually for hemophilia is deep-seated type of bleeding that may, but much less likely, you may have platelet type, like type of bleeding. And to remind you regarding the genes, the factor 8 gene is much larger than the factor 9 gene, and after which, when they started talking about the gene therapy, they started with the factor 9, then they jumped for the factor 8. And we know about the inheritance that it is X-linked recessive, that the father may transmit this gene for all of his daughters to be obligate carriers. And keeping in mind that even for hemophilias, the spontaneous type of hemophilia differs according to the severity. While for severe hemophilia A, you may have up to 50% sporadic hemophilia. It may be 30% for mild and moderate. And for hemophilia B, the severe type, it can reach to 40%. And for mild and moderate, it can be 30%. Regarding also the symptomatology and the risk stratification, we know that for the severe, we deal with a factor level less than 1%, which means that the factor is less than 1 unit per deciliter or 0.01 unit per ml, while the moderate, if it is above 1 but below 5%. This remembers us the importance of a prophylaxis, and when they started thinking of a prophylaxis, they thought of it, if there is a slight elevation of the factor just above 1%, as if you are converting your patient phenotypically from the severe phenotype to moderate phenotype. And this is the idea and paradigm after the prophylaxis, which was started early by the Sweden and Netherlands team. And we can see also the severity has something to do with the mechanism and the cause of bleeding. While in the severe type, spontaneous type of hemorrhage predominates, while in moderate and mild, usually you need a trigger, either mild or moderate type of trauma. And unfortunately, most of the hemophilias, whether for hemophilia again, or the most characteristic for hemophilias is joint bleeding. When we talk about hemophilia, we imagine as if we are talking only about the joints. But still, the muscle is very important. The muscular type of bleeding, if it is intramuscular, in a muscle that is large, like the thigh, the patient may be shocked. And if the muscle is small size, the patient may present to compartment like of a compression for the neurovascular bundle. But still, mucus bleeding may be sometimes a presentation, but less like hemophilia. And we don't know, and we don't want to reach this level. Unfortunately, we face some cases still now in Jordan where a patients are on crutches or on wheelchair because of the chronic hemophilic arthropathies. And regarding the life-threatening type of bleed, we have to go threshold, and we have to discover these early, because who can diagnose your patient who has intracranial bleed early, just you can give the factor early, and you may prevent a mortality, and you may decrease the morbidity. Now, idea behind the prophylaxis and what we are doing, and this is in the Jordanian protocol, and we are having now 100% prophylaxis regarding our patient. And we are using also the home therapy now. And we are for the primary type of prophylaxis, which means we started before 3 years in a patient who before having the second bleed and before the joint damage. How to reach all of these? Either we go to factor of replacement or non-factor type of replacement. And what you need regarding the factor, you need a factor which is safe and the factor efficacious. Actually, for the factors, we are facing different factors. Either they are derived, and we are having now the recombinant factor, but not all the factors, they have the longest half-life. And newly we have, apart from the standard half-life, we have also the extended half-life, but they are rare in our facility, and because they are costly. Now, for the efficacious factor, you need a factor which is effective, that can be administered, which has a longer half-life, and you need also a factor with less or even no viral transmission, and factor that is not associated with inhibitor. Because as we know all, have inhibitor, this is a big challenge for the physician, a big challenge for the patient. And if we encounter surgery for a patient who is having hemophilia, also having inhibitor, it is headache for all of us to follow this patient and to go to hemostatic. It is a hemostatic challenge for all of us. Now, to get rid of this viral infection and viral contamination, we have the recombinant. The recombinant factor nearly now substitutes all of the plasma derived. And it is there in most of the institutes. I can't say all of institutes in Jordan. And what is called the third generation recombinant factor, when we are not using human or animal protein through the manufacturing, final product is albumin-free, which makes and attenuates the viral transmission regarding these patients. And this is very important to remind us. I don't know, we don't have this. We don't have the slides. So, okay. This is the journey, which includes the timeline, patients with hemophilia, and the discovery of different factors. Now, for hemophilia and hemophilia B, we started using BCC, which is considered low purity and low concentrated factor 9, associated with factor 2, factor 7, and factor 10. After sequencing of factor 9 in early 1980s and factor 8 mid 1980s, and after that time, many started of the gene therapy, and if we can go and manufacture some of these factors, and the first actually recombinant factor 9 that is used in hemophilia B was the Benefix, which was approved later in 1997, and it started to substitute the already there plasma-derived factor 9.
When they started using the Benefix, and it first was approved in 1997, they started several studies. The first was for patients who were treated for plasma by derived factor 9, and the Benefix was started at that time. And the Benefix now is used as a treatment, also prophylaxis in patients with hemophilia B, and it is appropriate for all ages, and you don't use protein through manufacturing. The end product is free of albumin, and so there is attenuated viral transmission regarding this product. Also, more purification for the Benefix through nanofiltration, which is getting rid of any viral transmission. And we can imagine how safe this drug. We have 5 safety steps regarding the free agent in the manufactured Chinese hamster oil, and the extensive testing and removal of the viruses at the end by filtration. There are several studies for Benefix. I will not touch all of these, but I will start with the first study that is built up in 2001 for patients who were already on a factor 9 and shifted to Benefix. And this was a study which included 20 centers, and the duration was with a 3-month interval assessment, and they used not only for prophylaxis, but also for on-demand and for surgical related bleeding type of prophylaxis. And what they found after shifting their patients from the plasma-derived recombinant, they have found more than 90% excellent or good response after the Benefix. What is meant by excellent or good response? They followed what is called the 4-point scale for these patients, and the majority of hemorrhages were controlled even after the first injection. More than 80% of patients were controlled after the first infusion. And this is very important, because you can imagine if you control the bleeding early on and the blood is there in the joint for time, that your patient will be more prone for the hemorrhagiopathy, and another 11% will be controlled by the second. So more than 90% will be controlled after the first and the second infusion. Regarding the prophylaxis group, more than 90% also were considered excellent and effective according to their scoring and the scaling in the study, and more than 90% have controlled the bleeding during surgical intervention, whether it is stratified as minor surgical intervention or major surgical intervention. Now the question, what's about safety? 4 patients, only 4 patients developed minor allergic reaction, and there was no evidence of any viral transmission and no evidence of a thrombin generation. And when we ask why they were interested about the thrombin generation after Benefix, there in the history, when you were treating factor 9 deficiency hemophilia B before the recombinant and before the plasma-derived factor 9, you started with the PCC, which is considered low purity and low concentrated, but several factors, including factor 2, 7, 9, and 10. At that time, some of the adult age group patients developed thrombosis in several. After that, they decided that each factor 9 it is a must to consider if there is increment or increase in the thrombin generation, and there was no evidence of the thrombin generation after in this study. One patient out of 56 developed low titer inhibitor, reaching 1.2 Bethesda unit per deciliter, and after which you don't have to stop the treatment and you continued with giving benefits, but at higher dose for the patient when they developed breakthrough bleeding, and the inhibitor subsided and disappeared by month 19. And they concluded after this study, which was done in 2001, that Benefix is effective in treatment of patients with hemophilia B as a prophylaxis on demand and for surgery-related bleeding. And all of the hemorrhages which reached up 1,796 were controlled, and more than 80% of these hemorrhages were controlled after the first infusion, and with minimal side effect regarding only some minor allergy. After this study, they were brave enough to go for patients who were not started on a previous plasma derived. Now, what's about those patients who are previously untreated by plasma derived? And this is a multicentric study which includes actually 41 centers. And they decided to go also mimicking the previous study for on-demand prophylactic and surgical type of prophylaxis. And regarding the prophylaxis, more than 90% were considered excellent. Excellent according to the scoring system or a scaling system that is decided in the study. And 75% they have control of the bleed, which is episodic type of bleeding, which requested on-demand type by only one infusion, and another 15% were controlled after the second bleed, the second infusion. Regarding the adverse event, there was no increment and no viral transmission, no thrombin generation, and no, but some patients, they developed, actually 2 patients, they developed high titer inhibitor, and they were taken off the study. They concluded after this study that the benefits is safe and clinically effective as a preventive measure, as a prophylaxis, and as a treatment for episodic type of bleeding, what is called on-demand type of bleeding. Now regarding the children, because in the previous 2 studies, most of the children were above 6 years, and they imagined that this drug may not be beneficial for patients who are earlier, and they made this study, and they used this drug benefits even in patients less than 1 month, but now as a prophylaxis, and the prophylaxis was given once or twice weekly, and they included 23 patients. 77% of the patients, they had no spontaneous bleed, and 32 patients, they have no whatever bleed even after trauma. And for those who were on prophylaxis and their age below 6 years, and they developed breakthrough bleeding, their bleeding was controlled after 1 or 2 injections, reaching up to 89%. And this was considered, according to the response rating, it was considered excellent or good. And again, no patient encountered thrombosis, and there was no viral transmission. And they concluded from this study that Benefix can be used as a prophylaxis in patients who are ages below 6 years, and even in the infantile age group, and even in those below 1 month, by 1 or 2 injections per week. And the last 2 studies were for patients comparing the plasma-derived factor IX with the Benefix. This was a retrospective multicentric study which included 180 subjects, and they found that the frequency of allergic reaction and the frequency of inhibitor development, and sometimes they occurred concomitantly in the same patient. They were similar for those patients who were on plasma-derived or on Benefix. And the last study regarding the thrombogenicity. They actually calculated the thrombogenicity through the D-dimer, the prothrombin fragment 1 and 2, and thrombin antithrombin complex generation, and they found for Benefix that it was associated with the clinical, it was not associated whatever by thrombosis, and there was no change in the biomarkers that we said before associated with the thrombogenicity, and it was considered to be safe regarding this issue. And I will conclude with this. Benefix was the first recombinant factor IX that was licensed and released in 1997 and studied over 20 years for patients who were previously treated with plasma-derived and shifted to the recombinant, and also for patients who were not treated previously by plasma-derived, and is considered the treatment that you can rely on for prophylaxis, for on-demand, for episodic type treatment, and for prophylaxis during surgical intervention. And thank you.
Thank you, Dr. Wahid, for this excellent presentation. The floor now is open for questions. Dr. Habib.
For this excellent talk. Back in the private sector to treat leukemia, A and B. But I'm wondering that some companies doing the propaganda for protein complex, especially Hikma company. What's your comment about that?
Can you question? Hikma?
Or the thrombin? I was asking about protein complex.
Yes. Regarding
regarding this cases of Hemophilia A and B.
in the private sector, they are not.
And you are lacking how to treat Hemophilia A and B,
Yeah.
however it is there. But sometimes Hikman are you remember the complex. But you
Yes, prothrombin complex concentrate. Yes, actually for the PCC we have 2 types. We have the PCC octaplex, which includes 4 factor now, and there is another preparation with a 3 factor, but available now in Jordan is 2, 7, 9, and 10. And we have the activated prothrombin complex concentrate with the APCC, now called FIBA, which is factor 8 inhibitor bypassing agent. These are different. For the PCC now, it is recommended not for hemophilias, because you have a factor concentrate. For hemophilia A, you have the factor 8 concentrate, which is not included in the PCC. And for hemophilia B, you have the factor 9 concentrate, which is included, but you have the concentrate, you don't have to go for the PCC. PCC now used for warfarin reversal. If you have a patient who have warfarin intoxication by anemia and he having bleeding, you may consider according to the guideline of administration, according to the INR, and according to the clinical status and the bleeding status of the patient. Also, the severity stratification scoring system for the severity, you can go for vitamin K, sometimes for plasma, sometimes for the PCC as warfarin reversal. Now for the ABCC, which is also now available sometimes as donation, as Dr. Abdullah is the leader regarding the donation. Now we are using it for patients who have inhibitor. For patients with hemophilia A with inhibitor, or even for B with inhibitor, we are using the fiber if the Novus 7 is not available. For the Hikma, they have the PCC, which is not activated. Sometimes you can use it as a supply for factor 10 deficiency. You have 2 patients with factor 10, but we don't have a concentrate of factor 10 in Jordan. What we are using sometimes is PCC as the supply for this factor. Yes.
Thank you. Can I ask the status of long-acting multi-half the non-concentrates and or recombinant products, as well as where have we reached in the gene therapy in hemophilia B?
Yes. Thank you, Dr. Abdullah. For the first part, for the long-acting, which is now called extended half-life, factor 9, actually worldwide there are 3 types. There is the FC portion ligand, factor 9, and we have the albumin fused factor 9, and we have the pegylated factor 9, where these can reach a half-life of 100 hours. And it is recommended, if we have it, you will reach 1 time factor 9 long-acting to be given every 7 to 10 days. And this will be a great success. Actually, we don't have it in our facility, and I guess we don't have it in Jordan. Hopefully, we will have it in the future. But actually, this is the future for patients with hemophilia B when we have these long-acting. These 3 types, the FC, albumin, and the pegylated. Regarding the gene therapy, this is a long story. Actually, I have the chance to talk about gene therapy in hemophilia A and in hemophilia B, and we learned much about this issue. Actually, for hemophilia B, it was released, the gene therapy, it was released worldwide in November 2022. And they have an announcement, they started this type of a treatment. In Jordan, we did not share gene therapy with anyone. In Saudi Arabia, they have, I guess, 1 patient, they have a donation and share experience regarding gene therapy for also one of their patients. We did not start it yet. It is very costly. It may reach to 3 million for one patient. It will be very, very difficult. The idea behind the gene therapy, it is not that much complicated. It is an injection that can be given peripherally. You can give it in the peripheral vein. It is not that much magic. It is through a virus called adeno-associated virus. And these have different serotypes with a tropism to the liver and will make the liver producing what you need. It is not only for hemophilia, but also for many diseases in Jordan. I guess we are still late regarding this issue.
$3 million?
$3 million, yeah. Yes.
Which is reasonably cheap. This is curative treatment. And if you calculate how much factor you get from the first year, they survive for 50 years, you have paid for factors something like probably 5-6 times more.
Comparing the world between Ukraine and Russia, so
Any more questions? Well, if there are no more questions, again, I'd like to thank you very much, Dr. Ryan. Like also Pfizer for supporting this activity. Thank you.
Thank you.
Thank you everybody for joining us. Our next session will be with Dr. Mark Hitzel. He's a professor of medicine at the Division of Hematology at Mayo Clinic. He was the director of BMT program at Mayo from 1992 to 2008 and continues to remain active in the BMT program. He was the director of the myeloid disease-oriented group in Division of Hematology from 2002 to 2016 and was appointed chair of the Leukemia Committee of the ECON ACRIN in September 2013 after having served as a co-chair for the committee since 2001. He's the co-chair of Acute Leukemia Working Committee of the CMIP-MTR and became board certified in hospice and palliative medicine in 2013. And he's a member of the palliative medicine program at Mayo Clinic in Rochester. His research interests include clinical trials for acute and chronic leukemia, including blood and marrow transplantation, and supportive care of a blood and marrow transplant patient. He's an author for over 500 manuscripts and notable book chapters, and will be gratefully presenting an update about the revolutionary treatments in acute lymphoblastic leukemia. Welcome, Dr. Mark.
Thank you very much for that kind introduction. Can you hear me?
Yeah, we can.
Okay, well, thank you very much. It's a great honor for me to be with you today, even remotely. I was in Jordan about 10 years ago and had a wonderful stay there, and so I have fond memories of my time there. So it's a great honor for me to speak today. And my topic, as you can see, is acute lymphoblastic leukemia in adults. New multimodal treatment approaches are bringing improving outcomes. So these are my disclosures, mostly research support, and I'll talk about inotuzumab ozogamicin and blinatumomab and some new approaches. So there are 4 developments that have led to improvement in the outcomes in B lineage ALL, and this will be the focus of my talk today, will be the B lineage, because that's where most of the advances, as many of you know, has been made. And these 4 developments are the use of pediatric intensive regimens in the treatment of adolescents and young adults, the prognostic value of measurable residual disease assessment, the introduction of tyrosine kinase inhibitors for BCR-ABL positive ALL, and the addition of immunotherapeutic approaches to treatment. So this was a trial that we conducted in the United States that was led by the former CLGB, now the Alliance, with collaboration with a group that I work with, the Eastern Cooperative Oncology Group and the Southwest Oncology Group. And we used a children's oncology group treatment protocol that used intensified asparaginase steroids and vincristine, and applied this to adolescents and adults up to the age of 39. And you can see the distribution was similar in the different age groups. And we showed excellent results with a 2-year overall survival of 79%, supporting the benefit of these intensified regimens for young adults. And so this raised the question of whether we need to transplant adults with ALL. In the past, and certainly when I started out in my career, the thought was that all adults with ALL should get into remission and then have a transplant. And Dr. Matthew Wiedewelt, who is a colleague of mine, looked at 263 patients that were treated on this regimen I just showed you, the C10403 protocol, and then compared the results to 217 transplant recipients in the same age group who'd received a related donor, unrelated donor transplant with a myeloablative conditioning regimen, mostly including TBI. And the matched donors were found in 80% of these patients. And what he found, as you can see here, that the patients that got chemotherapy did much better than the patients that were transplanted, both for overall survival in the upper left and disease-free survival in the upper right. On the bottom left, you can see that relapse was similar early on, but then there were more relapses in the chemotherapy group after 15 months or so. The curve split, and that was significant. But the treatment-related mortality, as you can imagine, was much less with chemotherapy, and this contributed to the improved outcome. So this led to the idea that we don't necessarily need to transplant all of these patients in first remission, and perhaps even in the majority we do not. So I won't go into a lot of detail about the data utilizing minimal residual disease, but I will comment about this briefly. You're all familiar, I think, with this concept and the idea that we can now detect disease down to the 10⁻⁴, 10⁻⁵, and even with molecular studies, potentially down to 10⁻⁶, and that patients that have a good MRD response tend to have a better prognosis. And this led to studies that looked at the use of minimal residual disease along with the emerging genetic data that we now have in these patients to see if these modalities or parameters could supersede some of our traditional high-risk features, which I list in the first bullet: older age, high white count, longer time to complete remission, and poor cytogenetics. And so in this French study from now almost 10 years ago, they looked at patients with their MRD assessment and then looked at some selected molecular features. For the B cell patients, MLL gene rearrangement or an Icaros or IKZF1 mutation. And in the T cell patients, patients who were MRD positive and who did not have a Notch mutation or did have a RAS mutation or a PTEN alteration. And then they used these two factors to stratify the patients and showed that in patients who were standard risk and had neither of these features did better than the higher risk patients that had either both or one of these features, suggesting that the use of MRD and genetic features could potentially supersede some of our traditional high-risk features that we used to utilize. And then turning to pH positive or BCR-ABL positive ALL, this is a historical study that I show that we conducted through ECOG with the MRC in Great Britain. And you can see on the lower curve, the B curve, if you look at pre-imatinib, you can see the 19% survival. And this is traditionally why we always felt that pH positive ALL required transplant, because outcomes in these patients were so poor with chemotherapy. And in this study, we added imatinib initially after patients got into remission. That was a late imatinib group. And then the early imatinib group was the patients that we gave imatinib to during induction. And you can see that as we now know today, it's best to introduce the tyrosine kinase inhibitors early in the treatment of these patients. And as I'll show you, results have improved significantly later on. And then the fourth factor is the use of immunotherapy, primarily antibody-based. And I just show some examples here from a review article that a colleague and I did. You can see on the upper left, rituximab is the naked antibody that has been used in ALL. Blinatumomab on the upper right that I will talk about more. Some toxin-based therapies, but then the antibody drug conjugates in the lower right of the figure. Inotuzumab, calicheamycin is the primary example. And then, of course, in the lower left, chimeric antigen receptor T cell therapy or CAR T cell therapy. And I will touch on several of these. So let me turn and talk a little bit about the use of blinatumomab in a study that we did in ECOG Akron that I had the privilege of presenting at the ASH meeting. Many of you know that in the United States, the Food and Drug Administration approved blinatumomab some years ago for patients with relapsed refractory B lineage ALL, and then in 2018 approved it for use in patients who were MRD positive, both in adults and children. And blinatumomab, as you'll recall, is a bispecific T-cell engager molecule, so it takes a variable region of an antibody to CD19 on the B cells and the leukemic blast cells and links it to an anti-CD3 antibody that brings a T cell in proximity to the blast and lyses it. So we asked this question some years ago in ECOG. ECOG is now known as ECOG Akron, the E1910 trial, where we wanted to ask, does blinatumomab have a role in patients who have B lineage ALL or BCR-ABL negative and also achieve MRD negativity with induction chemotherapy? If we add blinatumomab at that point, is this beneficial? And this is the cartoon schema of the trial. Patients got 2 cycles of induction chemotherapy here at the top. If they did not achieve a more conventional morphologic complete remission, they went off treatment. If they achieved a complete remission, then they got an intensification with high-dose methotrexate and asparaginase for CNS prophylaxis. And then their MRD status was assessed at this point, and they were randomized either to get the control arm of 4 cycles of consolidation chemotherapy and then on to maintenance therapy, or at the investigator's discretion, they could go off to an allogeneic transplant. The treatment group got 2 cycles of blinatumomab, which, as you know, is given by a continuous IV infusion for 4 weeks at a time, so 2 of those rounds. Then 3 cycles of consolidation, then another cycle of blinatumomab, another cycle of consolidation, just consolidation number 5, and then a last consolidation with blinatumomab, and then could go to maintenance therapy. And these patients could also go off to an allogeneic transplant, and we wanted that to be done after they got these 2 cycles of blinatumomab. We stratified patients by age, their CD20 status, whether rituximab was going to be used, the intent of the investigator to transplant the patient, and then their MRD at randomization. So we randomized both the MRD negative and the MRD positive patients initially. And this was done in the United States, but also with colleagues from Canada and Israel, and it was a 1-to-1 randomization. Our primary objective was to compare the overall survival in the MRD negative patients who received blinatumomab plus chemotherapy to that of the patients who received the chemotherapy alone. We projected that we would have a minimum of 190 patients to be MRD negative to randomize, and our accrual goal, as you can see, was 488. And you can see some of our power calculations. We thought we had an 80% power to detect the 45% reduction in the hazard rate in the blinatumomab arm compared to the patients who got chemotherapy. So measurable residual disease was assessed centrally, and we did this by flow cytometry using 6-color flow based on the Children's Oncology Group study, and this was done by my colleague Elizabeth Paeta, and the cutoff was 10 to the -4 or 0.01% for positivity, for MRD positivity. So we enrolled a relatively older group of patients between the ages of 30 and 70, as there was a trial for younger adults going on around this time. The median age was right in the middle of that range at 51. We had a complete remission with incomplete count recovery. So this was by morphology of 81%. Most of these were complete remissions, as you can see. And the blinatumomab, we were able to give that by 72 and 96-hour infusions, and that allowed more patients to participate because the bag changes for the blinatumomab didn't have to be done on weekends. So this study actually activated in December of 2013. We enrolled our first patient in the spring of 2014, and it met its accrual in October of 2019. So just over 5 years to accrue. 286 patients were randomized or assigned at step 3, and that's the randomization you can see on the right here. So we had 224 MRD negative patients and 62 MRD positive patients. I don't show the baseline characteristics here, but they were well balanced between the 2 arms. Now you'll recall that, as I mentioned, blinatumomab was approved for MRD positive patients in March 2018, and this was during the conduct of the study. And we felt we could no longer randomize those patients, so they got assigned to arm C, which was the blinatumomab plus chemotherapy arm from this time forward. So the study concluded in 2019, and then patients were followed for another 3 years. And in September of last year, the Data Safety Monitoring Committee recommended the results be released in favor of effectiveness in the MRD negative patients. At that time, we had a median follow-up of just over 3.5 years. 22 patients in each arm, or about 20%, went to allogeneic transplant, so 80% of patients did not. And most of the patients received a minimum of 2 cycles of the blinatumomab. Remember, our goal was to give 4 cycles, and over half the patients got all 4 cycles. So these are the results of our primary endpoint. The black curve is the blinatumomab plus chemotherapy group, and the red curve is the control arm, the chemotherapy. And you can see that we had a highly significant benefit for the patients that got blinatumomab. Remember, these are MRD negative patients. You can see the hazard ratio was 0.42 with a p-value of 0.03. And across the bottom, you can see the deaths on the blinatumomab plus chemotherapy arm were 17, about half related to ALL and half from non-relapse mortality. And the chemotherapy arm, 20 died from disease and 17 from non-relapse mortality, and 2 were unknown. We saw similar findings for relapse-free survival. These are the curves shown here. This again is the MRD negative patients, and again, a highly significant p-value. Now recall we had fairly small numbers of MRD positive patients. This shows the curve for these patients. So the black curve is a mix of the patients that got randomized to blinatumomab plus chemotherapy and then the ones that were assigned. And the red is patients that were randomized to chemotherapy. Now, some of these patients actually ended up getting blinatumomab. They were randomized to chemo, so it was an intent to treat, and we needed to consider them as part of the chemo arm. But because of the benefits that had been seen with blinatumomab, some investigators took their patients to blinatumomab off study. But we still saw benefit. The p-value was not quite significant because of the smaller numbers. So in conclusion, in this trial, we showed that consolidation of blinatumomab combined with chemotherapy has shown for the first time an overall survival advantage for adult patients with MRD negative, BCR-ABL negative, B lineage acute lymphoblastic leukemia. So a subgroup that we feel had a more favorable prognosis, but again, blinatumomab was effective, suggesting that obviously these patients have some minimal residual disease that we're not able to detect with our assay, and they benefited from the regimen. We didn't see any concerning safety signals, and we think this represents a new standard of care for this group of patients. And the company that provided the drug, the blinatumomab, for the trial is going to be seeking a new indication in these MRD negative patients with the FDA, and that is in process. Now, the French did something similar, and they reported this at ASH in this abstract, and Dr. Bossel provided me with his slides. So this was, excuse me, just a moment. In this study, they gave blinatumomab during consolidation to high-risk pH negative.
Could you try again?
To high-risk pH negative B lineage patients. And so this was a retrospective study that was done. So they had shown in their previous study, and these were the slides that I showed earlier, that genetic alterations in MRD response were independent risk factors for relapse, and that patients with a suboptimal MRD response benefited from transplant. So remember I said the MLL or KMT2A rearranged or Icaros deleted, or patients with a high MRD, these patients had a poorer prognosis. And so they did a sub-study that they called QUEST, which was a phase 2 study that they embedded or nested in this 2014 B trial for high-risk patients, and gave blinatumomab in consolidation. And this was based on the BLAST study. This was a German study that showed the benefit of blinatumomab in MRD positive B lineage ALL and led to the FDA approval. And you can see over here the high-risk patients, in terms of overall survival, did not do as well. And in the BLAST study, you can see the benefit for blinatumomab. So what they did in this study, they had 489 patients overall in the GRAL 2014 B study. This sub-study cohort that got blinatumomab were 94 patients. Here were their eligibility. And then they had an internal control cohort, and these were patients that were treated before this QUEST sub-study was activated. So they compared these two groups, and you can see here that the blinatumomab was embedded in the chemotherapy backbone from week 12. So over on the right here, the red bars are the blinatumomab, and they gave 5 cycles, 2 in consolidation, 3 in maintenance, again by continuous infusion. And then patients that were eligible for transplant could go off to transplant. So these were the two groups. Again, this was retrospective. You can see that most of the factors here or subtypes, they were well balanced between the two. MRD1 was after induction and MRD2 was after first consolidation. And again, fairly well balanced between those two groups. Now, the patients that got blinatumomab, more of them became MRD undetectable at 72% versus 53% in the control arm. And the cumulative incidence of relapse was less in the patients that got blinatumomab, resulting in improved disease-free, although not overall survival. And these are the curves of the cumulative incidence of relapse. Black curve is the control patients, and the red is the blinatumomab treated patients, leading to this better disease-free survival, although overall survival was not impacted, and this may have been related to the patients being able to go to transplant. But again, suggesting that blinatumomab can also be a benefit in these higher risk patients. Now, blinatumomab, as you know, and I mentioned, has to be given by a continuous intravenous infusion. Excuse me. So this was a conclusion from their studies. I apologize. Just showing their higher MRD response rate, less relapse, and prolonged disease-free survival. And they mentioned the E1910 trial that I had shown you. So blinatumomab needs to be given by a continuous infusion. There's been interest in seeing if it could be given in an alternate fashion. And this was a poster abstract that was presented at ASH with some initial results using blinatumomab subcutaneously. So these were patients over the age of 18 who had refractory or relapse B lineage ALL. And these were the different cohorts that they looked at, giving these different doses, 40 micrograms, 120, 250, and 500. Initially for the first week, and then giving it 3 times a week in subsequent weeks. So a much easier schedule, certainly, than continuous infusion. And they saw good responses. And that they were improved as the doses were higher. And most of the patients, 14 of 21, so 2/3 were responders. And so they concluded that this was well tolerated, that it was effective, that the PK and pharmacodynamic profiles were consistent with those that were seen with the continuous intravenous infusion, no evidence of immunogenicity. They're continuing this in a dose expansion. But this will likely get FDA approved and will certainly ease the way to administer blinatumomab to patients. So I want to turn now and talk about inotuzumab ozogamicin. You're familiar with this. This is a humanized anti-CD22 antibody that's linked to calicheamicin. This is similar to Mylotarg or gemtuzumab ozogamicin, which is a CD33 antibody linked to calicheamicin and used in acute myeloid leukemia. So the Germans have presented some of this data at previous ASH meetings and gave an update at the ASH meeting just in December of last year. They gave it an induction followed by chemotherapy, and this is for patients over the age of 55. So they gave 3 cycles of inotuzumab and then consolidation. And the primary objective, obviously, was to assess the efficacy, response rates, and achievement of remission at 1 year after start of therapy, and then to look at safety. So this is the schema. You can see the 3 cycles of inotuzumab given here, and then this was followed by conventional chemotherapy, and then maintenance therapy. So they had a high CR rate of 100% in these 43 patients, and this was 94% in patients that got all 3 cycles. They had no early deaths. MRD after the second induction was 53%, and after the third was 74% for MRD negativity. And this was the timing of the cycles. And this is the overall survival on the left and the event-free survival on the right. And And you can see that this looks very encouraging. Certainly one would expect that overall survival in these patients would be probably half this with chemotherapy. So these are encouraging results, but relatively small numbers of patients. Now in the United States, Matthew Wiedewelt, who I mentioned earlier, through the Alliance, has conducted a phase 2 open-label multi-center study of inotuzumab followed by blinatumomab for older adults with Ph-negative CD22B lineage ALL. And this is the schema of this study. So 1 cycle of inotuzumab. If the patients have adequate cytoreduction, they get another cycle of inotuzumab and then go on to blinatumomab. If there's no benefit after 1 cycle, they can go on and get 4 to 5 cycles of blinatumomab. And this is an untreated older adult cohort. These were patients over the age of 60 who were thought to be transplant ineligible. And this study has completed, and the results are being submitted for the upcoming ASCO meeting this June. So we haven't seen the results yet, but this hopefully will be encouraging results. And then what about CAR T-cell therapy? This was some data from the ZUMA-3 trial, Brexucabtagene, autoleucel, KTE X19. So this was led by Dr. Shah from the Moffitt Cancer Center, and this was for relapse and refractory B-cell ALL. And this ZUMA-3 study led to the FDA approval of CAR T-cell therapy in all adults. Up to now, we just had the Novartis product that was for patients up to the age of, I think, 24. And so what he did was compare the results with the CAR T-cell therapy to historical patients who got blinatumomab or inotuzumab or chemotherapy. These are small numbers, as you can see. There are 2 cohorts here. Some patients previously naive to blinatumomab or inotuzumab, and then patients who were previously treated with these two agents. And so what they found was that the CAR T-cell therapy was clearly superior in patients who had gotten chemotherapy but had never seen blinatumomab or inotuzumab compared to the CAR T-cell therapy. And obviously this was a highly significant p-value with the median overall survival not reached in the ZUMA-3 and the 5.5 months in the chemotherapy arm. Now, perhaps more interest is what about the patients that were exposed to blinatumomab or inotuzumab? And you can see that their outcomes are not as good with CAR T-cell therapy, and this has been shown in the pediatric population as well, but still superior to what is seen with patients who did not get CAR T-cell therapy and had been previously treated with blinatumomab or inotuzumab. And if you lump all these patients together, both whether they were exposed to blinatumomab or not, you can see that this survival benefit persists, not surprisingly. So it suggests that CAR T-cell therapy is certainly a very effective treatment, as we've seen in children and now shown here in adults. And then last week was the tandem transplant and cellular therapy meetings here in the United States, and Dr. Shah presented an update from the ZUMA-3 trial looking at different subsets of patients. So this was patients with lines of prior therapy. If they only had 1 prior line of therapy, complete remission rate was 87% versus 70% with 2 or more lines of therapy. Median duration of response, interestingly, was longer in the patients who'd had more prior therapy, but the median overall survival was superior for the patients who had 1 prior line of therapy. If you looked at prior blinatumomab, the patients who had not had prior blinatumomab, as had been seen in the previous studies, 83% CR rate, median duration of response over 18 months, and overall survival 47 months versus lower results for patients who'd had prior blinatumomab. And then looking at patients who'd had prior transplant and then relapsed and got CAR T-cell therapy, similar CR rate, whether you had a prior transplant or not. median duration of remission was better for the patients who had not been previously transplanted, and their survival was better. So not terribly surprising results, but gives us some sense of how patients may respond depending on their prior therapy. So let me turn now, in the time I have left, talk about pH positive ALL or BCR-ABL positive ALL. There's some relatively recent data from the MD Anderson group combining the second and third generation tyrosine kinase inhibitors with their hyper-CVAD regimen. And this was a propensity score analysis matching patients and showing that giving ponatinib with hyper-CVAD seemed to have superior results compared to patients that were getting dasatinib plus hyper-CVAD, both event-free and overall survival. And then we had the D-ALBA trial from the Italian group, and you saw this in the New England Journal a couple of years ago, combining dasatinib now with blinatumomab, phase 2 trial, 63 patients. You can see the median age was 54. These patients got steroids and then 3 months of dasatinib, and then were given blinatumomab for 2 to 5 cycles. So 98% had a complete remission with dasatinib alone. Only about a third had a molecular response. But that increased to 60% after the second cycle of blinatumomab, and 24 patients, I should say, underwent an allogeneic transplant. You can see here the very encouraging overall and disease-free survival for the overall cohort with a low relapse risk. And if they stratified the patients or subdivided them by their Icaros, whether they had Icaros or not, either alone or with other abnormalities, survival was not quite as good.
Please, doctors, we need no more see the slides.
Hello?
Hi, we need no more see the slides now, Dr. Lotus, maybe from your side.
You can't see my slides?
Yes, we can see now.
You can see now?
No, we can't see.
Let me try again.
Just, can you reshare it? We just lost
Yes,
it.
I'm going to reshare.
Yes. Good now.
Presentation.
Can you see them now?
We can see. Thank you, Dr. Lotus.
I'm sorry, you can't see them?
We can see. Yes, thank you.
Okay, thank you. So this was the dasatinib plus blinatumomab showing the excellent outcomes. Not quite as good if they have an Icaros mutation, but still very favorable. And then Dr. Short from MD Anderson presented data at the ASH meeting in December combining ponatinib with blinatumomab. So building on the D-ALBA trial from the Italians, and this was a subgroup analysis. So you can see the ponatinib, they initially gave it at 30 milligrams per day and then reduced it to 15 milligrams to minimize vascular toxicity if the patients achieved a complete molecular remission. And the orange is the blinatumomab, and then the green is intrathecal therapy with methotrexate and cytarabine. And you can see they had a very high conventional complete remission rate, only one early death. Major molecular remission was 97%, and complete molecular remission was at 87%. So these results look encouraging as well. In the United States, and then this is the event-free survival and the overall survival from this study, and they've just published this in a manuscript in Lancet Hematology, so you can refer to that. So in the United States here, my group, the ECOG-ACRIN group, is leading an intergroup trial where we're going to compare either ponatinib or dasatinib, and this is going to be investigator choice depending on their comfort with using ponatinib. And there'll be a run-in with steroid and tyrosine kinase inhibitor, either ponatinib or dasatinib, and then patients will be randomized to get on the bottom TKI plus steroids plus chemotherapy, and this will be the hyper-CVAD regimen versus TKI, steroids, and blinatumomab. And one of our endpoints will be MRD negativity. If patients achieve MRD negativity, they can go off to TKI maintenance plus or minus a transplant. If they're still MRD positive, then it's second-line therapy is at the investigator's choice, and they can actually cross over and get the other form of therapy. We had at one point hoped that we could actually try to randomize patients to tyrosine kinase inhibitor maintenance versus an allotransplant, but we didn't have the numbers to do that. And that would also have been, I think, a difficult sell to patients. And I don't have time to go into that here, but there's certainly been a lot of interest in patients who achieve MRD negativity to ask the question, do they really need a transplant? And, there's data suggesting that they may well not. And certainly that's a discussion that I have with my patients if they are pH positive and they become MRD negative with treatment, that we don't necessarily need to transplant them in first remission, as we have always considered doing in the past. So with that, I'll conclude. I've discussed the 4 developments that I think have fueled the progress in B lineage ALL: use of pediatric regimens, use of MRD for prognostic assessment and guiding therapy, introduction of tyrosine kinase inhibitors, and then immunotherapy. In the E1910 trial that we conducted, I showed you that blinatumomab added to chemotherapy improves outcomes in MRD negative ALL. The initial 1 trial from the Germans suggested that inotuzumab improves outcomes in older adults. CAR T-cell therapy improves outcomes in relapse refractory ALL. And we've also, I didn't show this data, but there's data showing nice responses in patients who are MRD positive. And certainly there's discussions about moving CAR T-cell therapy up earlier in treatment, potentially using it in patients who are MRD positive. And then blinatumomab plus tyrosine kinase inhibitors appear to improve outcomes in pH positive ALL. And so Dr. Advani on the upper right wrote this editorial recently about showing will chemotherapy be replaced by immunotherapy up front for patients with ALL, both pH positive or pH negative. And as I mentioned here, chemotherapy, I think, is going to play a diminishing role in the treatment of these patients. So I want to thank the authors who provided me with their slides from their ASH presentations, and then my colleagues here in the United States in the National Clinical Trials Network who came together to conduct many of the trials that I've mentioned here. So thank you again, and thank you very much.
Thank you, Dr. Mark, for this elegant and very comprehensive talk. Any questions from the audience?
Unmute here.
Can I ask you about your experience on VOD and anotuzumab? How frequent is the side effects or?
With the inotuzumab?
Yeah, yes. VOD, occlusive disease, with the use of this drug.
Yeah, well, that's certainly a risk. It occurs in a minority of patients. We actually put all our patients on ursodiol or Actigol as prophylaxis, as we do in transplant, to try to minimize that. If we think that the patient is a transplant candidate, as they often are if they're relapsed or refractory, and we give inotuzumab, then we try to limit the number of cycles they get to 2 cycles or 2 months of therapy, to try to also minimize the risk of them getting veno-occlusive disease or sinusoidal obstruction syndrome after transplant. So between ursodiol and minimizing the exposure, we think that we can minimize the risk of the liver toxicity, which is really the main concern with that.
Thank you. Dr. Khalid, do you have a question, Dr. Khalid?
Yeah, I have two things, one clarification and one question. Thank you very much, Professor Litza, for a very nice comprehensive talk. We're facing patients with B-cell ALL patients who are getting, on a diagnosis P53 mutation and high variable allelic ratio. In our center at King Hussein Cancer Center, we're testing it by next generation sequencing. And those patients, sometimes they're achieving MRD negative, even P53 negative very early on after first or second cycle of hypercVAT. So would you recommend to proceed with allogeneic bone marrow transplantation, keeping in mind that we don't have all of these immune therapies at King Hussein, blinatumomab, inotuzumab? Would you recommend to proceed with allogeneic bone marrow transplant for those patients after induction with hypercVAD, having MRD negative, P53 negative, and the other group who continue to be MRD positive or P53 positive?
So I think I understood the question. So patients that get hyper-CVAD and achieve an early MRD negative remission, would I recommend transplant?
But they are P53 positive from the start.
P53?
Yes.
I think I would recommend a transplant in that setting. I certainly take into account their MRD status, but I also look at their genetic risk factors and take that into account. And I think a patient in that situation, and that's fairly uncommon in ALL, but I think a patient in that situation, I would still lean toward transplanting them if they had a suitable donor and were not at high risk for transplant-related complications.
Yeah, another question regarding, most of those ALL patients were available immune therapy, they're getting immune therapy and relapse, and even for MRD positive, residual MRD positive. What do you think, where do you see the CAR T cells for those patients? As you did mention in your slides, in your presentation, that those who got immune therapy, especially blinatumomab, had lower responses than those patients who didn't get, and better survival in those who didn't get immune therapy before the CAR T. Where you would put the CAR T after all of these immune therapies prospectively? Thank you.
Well, I would still, so you're saying if someone relapsed and they got blinatumomab or inotuzumab and say, or say they've gotten blinatumomab or inotuzumab and then they've relapsed, I would still think about giving them CAR T cell therapy. I would be more inclined to transplant them. One of the other questions in the field is if someone gets a good response to CAR T cell therapy, is that as good as a transplant? Do they need a transplant? And I think that's an unsettled question, and that needs to be individualized for each patient. But I think, if they previously got blinatumomab or inotuzumab and then get CAR T cell therapy, I would consider transplanting them again if they're a suitable candidate, just because their survival isn't as good if they've had those prior immunotherapies.
Thank you very much. Thank you.
If there are no questions, thank you again, Dr. Lotus, for your precious time, and we hope to see you next time face to face in Jordan.
Well, thank you very much. It's a great honor again to be with you and speak today. All the best. Take care.
Thank you very much. Thank you.
Bye-bye.
عادي استوي بس.
Dr. Haifa?
Yes,
Can we start?
yes, I'm ready.
Could you open your camera?
Yes.
Thank you.
Good afternoon. I am Dr. Mohammed Saudi, medical oncologist from Royal Jordanian Medical Services. Dr. Mohammed Abidat, consultant oncologist at Royal Medical Services. It's our pleasure to moderate upon this session. First of all, I'd like to thank the audience and the guests from everywhere. And also, I'd like to thank Dr. Abdullah Abadi and Senior Doctor in Jordanian Society of Hematologists for organizing this scientific event. Also, I'd like to thank sponsor. It's my great pleasure to introduce you our honorable guest, Dr. Haifa. You are welcome, Dr. Haifa. I will present Dr. Haifa briefly. Dr. Haifa Catherine Al Ali, University Hospital of Palais Zali, Germany, is a professor for translational oncology and the director of the Kickenberg Cancer Center at the University Hospital of Ali. She is a senior consultant in internal medicine, hematology, and oncology. The scientific focus of her work has been in the field of myeloid malignancy, myeloproliferative neoplasm, myelodysplastic syndrome, and acute myeloid leukemia. Her research has focused on the implementation of the phase 1 to 4 clinical and translational study and the investigation of the relevance of genetics and epigenetics changes in myeloid diseases and predictive factor of response. Dr. Catherine Al Ali research has been published in journals such as the New England Journal of Medicine, Blood and Leukemia. So it's great to have you here, Dr. Catherine, and we are excited to hear about you about the treatment and management of updates of new myelofibrosis. So the floor is yours, Dr. Catherine.
First of all, assalamu alaikum. I'm really, thank you very much. And it is really an honor for me always to communicate with my colleague from Jordan. And I think I will just put my presentation. Could you see that? Could you see my slides?
Yes, we can see your slides. You can start.
Okay, today I would like to just summarize what we have learned about the use of ruxolitinib in the treatment of myelofibrosis, and then outline some of the limitations, especially in patients with cytopenia or adverse events. And then I wanted to show what alternatives do we have and maybe a future perspective where the journey in the treatment of myelofibrosis is going in the next few years. These are my disclosures. Yes, what have we learned in more than 10 years after the approval of ruxolitinib? I think we all agree that ruxolitinib has really changed the treatment landscape of patients with myelofibrosis. We have learned regarding response that there is a very strong correlation between the stage of the disease and the response. As we know, and it is no surprise that the more advanced and the more higher risk IPSS patients that are being treated with ruxolitinib, the less likely the response is going to be good. And also the duration of the response is only limited. But we have also learned that we need an adequate dosing of ruxolitinib to have a good and long-lasting response. From the COMFORT trials or from the JUMP trials, from the real-world data we have now available, we know very well that, the dose of ruxolitinib depends upon the platelet count. And we know very well that patients with low platelets, between 50 and 100,000, are recommended to be treated with only 5 milligrams twice daily. Although we do get responses, as you can see in the red bars, but definitely these responses are much less than that what we see in patients treated with higher dosing, because we could treat these patients because of their higher platelet count. So this is, I think, one of the major limitations. Low platelet counts limit the dose of ruxolitinib, and with this, the response is also less marked than if we could treat adequately. These are the main facts we have learned in the last 10 years regarding response. What about survival? Again, the long-term follow-up data of the COMFORT trials show very clearly, both the COMFORT-1 in the United States or the COMFORT-2 in Europe, show very clearly that definitely patients with high risk IPSS, intermediate 2 and high risk, do live longer if they are treated with ruxolitinib compared to patients treated with traditional non-JAK therapies. But again, if we look closer, the survival benefit is mainly seen if patients are being treated rather early after the diagnosis, in the first year with ruxolitinib. This is the blue survival line, compared to patients if treatment is started many years after the diagnosis. And I think this again reflects the nature of the disease. MF is a progressive disease. And the later in the stage of the disease, the treatment is started, the less likely there will be a survival benefit. This is what ruxolitinib is considered. But what about MF-related thrombocytopenia? We know very well that thrombocytopenia that is due to the disease and not due to the treatment is a very bad prognostic factor for survival in the pre-JAK era. But again, even with ruxolitinib, still patients with baseline low platelets, these are the blue survival lines, have definitely a less survival advantage, even if treated with ruxolitinib, compared to patients who have higher baseline platelet count, again reflecting the nature of the disease. As we know that the low platelets are usually patients in very advanced and late stages of the disease. A second MF-related problem, even more frequent than thrombocytopenia, is anemia. And as you know, after 1 year of diagnosis, almost half of our patients suffer from anemia with hemoglobin less than 10 grams per deciliter, and actually 1/3 of these patients become transfusion dependent. And again, we know very well from all the risk models we have available for myelofibrosis that anemia is really a very negative prognostic factor for survival. This is traditional without ruxolitinib. What about ruxolitinib? You know very well the major adverse event of ruxolitinib is anemia. And if we look at the data of the COMFORT-1 or 2, almost every second patient had at least a grade 3 or 4 anemia, and a grade 3 means a hemoglobin below 8 grams per deciliter. Although anemia is less in patients treated who are less high risk, especially patients with intermediate 1, as we only have 25% anemia, but still anemia, and everybody who treats patients with ruxolitinib agrees that anemia is a major issue in the challenge in the treatment of these patients. Nevertheless, so we have this very challenging situation, a disease causing anemia on one side and a treatment that has a frequent adverse event of anemia. But what we have learned that the treatment-related anemia from the survival point of view is not the same as anemia due to MF. Anemia to MF is really very bad in terms of survival. But ruxolitinib-induced anemia is not prognostic negative. But indeed, if our patients get anemia under ruxolitinib, as I said, anemia alone is not bad. But if these patients become transfusion dependent and remain transfusion dependent, then indeed the long-term survival of transfusion-dependent patients treated with ruxolitinib is much less than patients who are only anemic. So transfusion dependency on the long term, like in most of other diseases, under ruxolitinib does have a negative impact on long-term survival. And indeed, if we look at the real-world data, what are the most common reasons for discontinuing ruxolitinib? It is the high-risk patient, as we have said, because the response is less in these patients. it is transfusion dependency, and it is low platelets, because as we said, low platelets limit the dose and the response is also less. So in summary, I think when we are faced with a patient with myelofibrosis and we are thinking about the treatment with ruxolitinib, I think it is important not to look at the hemoglobin level, but to look at the platelets, because the platelets should guide our initial dose and also the follow-up dosing. And I think MF-related anemia is not a contraindication for the use of ruxolitinib, as I just showed you an example here of the COMFORT-2, where at baseline almost half of the patients were MF, because of MF, had anemia. And I think we should never forget that our patients could also have other causes of anemia, which might be very easy to treat. And we all have learned over the last 10 years the dynamics, the incidence, how to manage anemia under ruxolitinib. And I think it is very, very important to have these close follow-ups in the first 12 weeks when we start ruxolitinib to adjust the dose, not to look at anemia that much, but more on the platelet count. And we all have learned again, if I have a low erythropoietin level in a patient treated with ruxolitinib and the patient becomes anemic, then a bridging with erythropoietin seems reasonable without any negative side effects. A very interesting question, you know, we are treating now some of our patients with more than 10 years with ruxolitinib, and always the question arises, okay, what about the bone marrow fibrosis? Is there a correlation between survival, between response, and the changes in the bone marrow fibrosis? At last ASH, we had a very nice oral presentation actually done for the momelotinib trial, which was comparing another JAK inhibitor with ruxolitinib, and they had a long follow-up. And the data showed very, very clearly that despite anemia, the bone marrow fibrosis does not predict outcome at all. And that's why I'm always saying, outside clinical trials, I don't routinely do a bone marrow biopsy for patients who have adequate responses. But here, for the first time, we have it on a scientific basis that bone marrow fibrosis does not correlate with survival or response under JAK inhibitors generally, and particularly for ruxolitinib. And I think this is a very nice information. So if I summarize all that what we have learned in the last 10 years, I think on the one side, we have these challenging myelofibrosis patients, the so-called cytopenic patients with thrombocytopenia or anemia, and these patients are more likely to have primary myelofibrosis. They usually have higher risk disease. They have a lower JAK2 allele burden. They have a lot of additional somatic mutations in the JAK-STAT pathway, and these are the patients with a less favorable response to ruxolitinib and a real worse outcome and shorter survival. On the other side, we have a good drug, but we have a lot of hematological, mainly anemic adverse events under treatment. And we know, despite very good initial responses, that over time, every second patient loses response, so that after a median of 3 years, almost half of the patients who initially responded lose the response. So we still have challenges, although we do really have a great drug, which helps a lot of patients with ruxolitinib. So the question is, what alternatives do we have? I think in the era of all these JAK inhibitors, I think it is very, very important not to forget the option of allogenic stem cell transplantation, particularly in the younger cytopenic high-risk patients. And that's why I just wrote the NCCN guideline, just to remind ourselves, because we tend to forget that for high-risk cytopenic patients, younger, with an HLA identical donor, transplantation remains a curative treatment option for these patients. But the majority of patients are not eligible for transplant. So the question is, what alternatives to ruxolitinib do we have? We discussed erythropoietin, and we know about the use of erythropoietin and anemia for more than 20 years, even in myelofibrosis. And indeed, if we have patients that do not have that many symptoms, that do not have massive splenomegaly, that have low erythropoietin, then I think it is justifiable to have a trial with erythropoietin, especially if the EPO level is below 500 units. Another alternative, which I like personally very much, particularly in patients with severe thrombocytopenia, are the immune modulators like thalidomide. This is cheap. In combination with low-dose prednisolone, we might get good hemoglobin, but also good platelet responses in about 1/3 of the patients. And then we have danazole. You know, danazole has its own problems, but nevertheless, this could be an alternative if you don't have any other option, particularly for severely anemic, transfusion-dependent or severe thrombocytopenic patients. But I think all these treatments, you know, we don't have any phase 3 trials, but still, for the individual challenging patients failing ruxolitinib or who have contraindications, particularly because of the very low platelets, I think we should not forget that we still have some old traditional medications. Now, what about the other JAK inhibitors? I just, you know, we talked about ruxolitinib. I don't know whether in Jordan you have fedratinib or pacritinib approved, because fedratinib, for example, is approved in the in Europe and United States, first line or second line after failure of ruxolitinib, and pacritinib is also approved as second line in the United States, particularly for patients with severe thrombocytopenia. So if I have the option of all, and then we have momelotinib, which is expected to get an approval in this year. So the question is, in the near future, can we identify subgroups of patients where you would say ruxolitinib is suitable for this patient, fedratinib is better for this, pacritinib is better for that? And I think, yes, there are some options, particularly as second line option. Sorry, it just wants me. Oh. I don't, something happened here. I cannot move it anymore forward. I can't move my presentation.
Could you stop share and share it again?
Sorry?
Could you stop sharing this and try?
Yeah, and then try to share it again. So, yes. This is again fedratinib. Is fedratinib more efficacious than ruxolitinib in the first line setting? There is no. Sorry?
No slides.
No slides? Oh, but I'm seeing my slides again. I will share again.
Please.
Could you see them?
Yes.
Okay. Now it's fine, okay? Yes, fedratinib. Is this more efficacious than ruxolitinib in the first line setting? We don't have a head-to-head comparison, but my answer is no. It is comparable in terms of spleen, in terms of symptom response to that what we know from ruxolitinib. In the second line setting, after failing ruxolitinib, fedratinib can induce good spleen responses and symptom responses in about 1/3 of the patients. It is a good drug. But what is the advantage, or where is the indication for fedratinib in the first line? I think it is mainly limited to those patients with low platelets at baseline, those between 50 and 99,000, because indeed, these low platelet patients, you can treat with a full dose fedratinib, and you will have much less thrombocytopenia than ruxolitinib. So I think this is an advantage of fedratinib. You will have less thrombocytopenia in patients who have MF-related thrombocytopenia. What about anemia? We have such an issue with anemia. I will give you an answer. No, fedratinib is not an alternative to ruxolitinib. If you look at the incidence of anemia between ruxolitinib and fedratinib, they are exactly the same. And also the dynamics of the hemoglobin drop under fedratinib is exactly similar to that what we know from ruxolitinib. So anemia is not an argument for the use of fedratinib in anemic patients. What about momelotinib, you know, the data were presented at last ASH, and as I said, they are submitted for approval in the United States and Europe, and we will have the data, the drug available in the next few months. And these data are based on the results of the phase 3 Momentum trial, where patients second line, anemic, only anemic patients, were randomized between momelotinib and danazol. And indeed, what we could expect is that about 1/3 of your transfusion-dependent patients, this is a real unmet need in MF, can become transfusion independent. And the adverse events of momelotinib are not that bad. It is rather well tolerated, and you could treat patients with low platelets as low as 25,000. So momelotinib as second-line treatment for anemic patients, thrombocytopenic patients might be a good option. And as I said, particularly in those patients with low platelets, still about 1/3 of these patients, you could expect to have a good transfusion response, and the patients become transfusion independent. As I said, this will be available, I hope, in a few months. What about pacritinib, which is already approved in the United States but not in Europe? This is a really good second-line treatment for patients with very severe thrombocytopenia, even those that are transfusion dependent regarding platelets. And it has some issues of bleeding, some cardiac toxicity, and in addition, at last ASH, it was very nicely shown that pacritinib could even induce transfusion independency from anemia. So again, if I have a cytopenic patient and I would have all these 4 JAK inhibitors available, I would choose momelotinib for the transfusion-dependent anemic patient, and I would choose pacritinib for the severe thrombocytopenic patients. And to be honest, for all other patients, I would use ruxolitinib because, you know, we have so much experience and we know the long-term efficacy and safety of that drug. So the question is now finally, why should we always try one drug, wait until it fails, and then come to the next? And we know in hematology and in oncology, we are used to combination, even triplet and even quadruplet. And in MF, we are still treating monotherapy. So I think, why not use a JAK inhibitor as the backbone, and then maybe add another drug from another class from the very beginning? But to me, even more enthralling is to do a sequential treatment approach, meaning starting with a JAK inhibitor, wait for 3 months. If the patient is doing well, have no side effects, then we should continue, or we could continue with the treatment. But if the patient still has a spleen or symptoms or has adverse events, then we could maybe add another drug. And indeed, we have many classes of drugs that are being combined with ruxolitinib mainly in patients either from the beginning or, as I said, sequential or the add-on approach. And indeed, an example is, you know, the BET inhibitors are very promising. The Manifest-2 trial, this is a phase 3 trial, combination ruxolitinib plus the BET inhibitor pelabresib, has finished recruitment just a few days, and we will expect to have the results maybe at the coming ASH. And so maybe, depending on the results of this phase 3, we will have this combination approved for the patients in 2024. Another very interesting BET inhibitor is now also being evaluated in phase 1b and 2, and I think this is still too early, and so on. So we have a lot of combinations coming on. An example, a very fascinating combination is ruxolitinib or fedratinib plus luspatercept, which we know from MDS, in patients who are transfusion dependent. So I think in the near time, we will have combinations that might fit the one or other subgroup of patients. And just to show you the final results of the phase 2 trial that were presented at ASH, if we use the combination compared to ruxolitinib monotherapy, and another interesting data that were presented at last ASH was a combination ruxolitinib with the PI3K delta inhibitor, showing that patients might have a very nice symptom response. So my conclusions are that we all agree that ruxolitinib is a real major breakthrough in the treatment of patients with myelofibrosis, yet we still do have limitations and challenges, both in terms of safety, particularly hematological adverse events, but also the loss of response over time. And we have a lot of newer JAK inhibitors coming that might be an option for certain patient groups. And I think an alternative in the near future would be the combination or the add-on strategy where we will use both the JAK inhibitor plus another class of drug. And with that, I would like to thank you very much and would be more than happy to take questions. Thank you.
شكرا دكتور عيد يعطيك الف عافيه. يعني بصير نسألك كم سؤال؟
Sure. طبعا.
Those patients with myelofibrosis and do not ask really, do you have ruxolitinib have any role? And do you think it has a lot of role in those patients? Do you think the dose is similar for those with spleen?
Sorry, the sound is not that clear. Ruxolitinib, I have understood ruxolitinib.
Myelofibrosis and don't have spleen.
Yeah. Without specifically, no, I don't give them ruxolitinib, to be honest.
No.
And if they don't, only those if they have symptoms, then yes, I would consider using ruxolitinib. But otherwise, we don't have any data, although we do have survival benefit, but we don't have really data proving that ruxolitinib will delay the progression of the disease if we treat patients without spleen. And we have these issues with anemia, thrombocytopenia. So to be honest, we do not treat these patients with ruxolitinib.
Do you think that's those who progress to acute leukemia has ruxolitinib have any role in such patients with chemotherapy?
With AML? With acute transformation?
Acute leukemia.
Yes, shortly after the approval of ruxolitinib for the treatment of myelofibrosis, there were a lot of trials and data, even trying doses up to 50 milligram ruxolitinib twice daily in patients with acute leukemia. But indeed, there was no chance because, there was no response. But what is interesting, and this is something we are doing now, to combine a JAK inhibitor with a hypomethylating agent. And we are actually conducting now in Germany, it's my trial in patients with accelerated phase, because we know, the blasts are being produced in the spleen. So we need something that reduces the spleen. The JAK inhibitor is good. So I'm combining fedratinib with the oral azacitidine, CC486, hoping to use the epigenetic plus JAK-STAT modification to prevent transformation to AML. As I said, these are still a trial, and we hope that this combination will help. But the JAK inhibitor mono is not really very effective.
Can I have a question? Yeah, thank you very much, Dr. Catherine. Very nice always having you with us.
Thank you.
I know this is good to have all of these drugs and new medications that we don't have. I do remember I asked for a fedratinib for one patient on non-formulary basis, and he got to Germany to get a transplant. So my question, for the fraction of patients who fail ruxolitinib, tolerating, but he's failing. I mean, he responded then failed. Where you go, how you go, would you consider at this point going to allogeneic bone marrow transplant in case you would have a cyclic match related? Because to my understanding, I'm an expert in myelofibrosis, all of these second lines really are barely tolerated. For example, fedratinib. How you would manage patients who is failing ruxolitinib? Would you go with a second line, third line, or would you proceed with allogeneic bone marrow transplant in case if you have a cyclic match or even haplotransplant?
Yes, thank you for this very important question. And I always say this is a €1 million or dollar question. What is the right time for transplantation? Transplant in MF is not an easy issue. We have, even in younger patients, a mortality of up to 50%. And the challenge is that, transplant is benefiting patients who don't really need transplant, who will do good without transplant. And we know very well that patients failing ruxolitinib and are being taken to transplant do much less well than patients who are responding and are being transplanted. And this is really a dilemma. Today, most of the patients are elderly. If they are young, indeed, the option remains, and that's why I stress this option. But for the majority of patients, I go to second or even third line, even fourth line treatment. And, MF does not change from today to, we have time. And I always watch if the patient is changing, particularly the blood. And if I see that there are new changes, then I would advise the patient to take the transplant before transforming to AML. But as I said, with the availability of all these treatment options, it is really very, very difficult to decide what is the right time to take somebody to transplant. And just maybe as a tip, if you don't have another treatment and the patient is losing response to ruxolitinib, then you could taper ruxolitinib, stop ruxolitinib for 2 to 4 weeks, give hydroxyurea or whatever, and then reintroduce ruxolitinib. You might have a very good second response, mostly not as good as the first, but you might get a second response. And indeed, I have patients whom I have treated 3 or 4 times with ruxolitinib, tapering, stopping for a few weeks, and restarting ruxolitinib, because unlike CML, we don't have point mutation.
Yeah, thank you very much.
I have a question. Do you think that ruxolitinib has its effect on the fibrosis by itself? And do you think that's better to take the response of ruxolitinib regarding thrombosis has any role?
And thrombosis, I don't think that it does have that much role. Thrombosis or bone marrow fibrosis? I'm sorry.
Fibrosis.
Fibrosis. Yes, it doesn't. It doesn't. It doesn't have any impact on fibrosis. And as I showed you, the data, these were hundreds of patients. And, I don't care about fibrosis, to be honest, because many of our patients sometimes transform, from PV directly to AML without having fibrosis. So the effect on the bone marrow fibrosis could be neglected.
Dr. Aita, thank you again. I have a question. It's well known that 60% of myelofibrosis patients have JAK2 mutation. The other 40% may have other mutations like MPL and CALR. Does it matter in terms of the treatment of JAK2 inhibitor to have other mutations than JAK2?
No. No. The only difference maybe is in terms of response, no, but in the terms of duration, we know triple negative myelofibrosis are really bad people. I mean, bad from their survival chances. And this is maybe coming back to the issue of transplant. If I have a young triple negative myelofibrosis patient, I would treat this patient with ruxolitinib. He or she is expected to have a response similar to JAK2 mutated or calreticulin mutated patients. But then, as soon as this patient responds and I have a donor, I will take this patient immediately to transplant, because we know that the duration of response is short and their transformation rate to acute leukemia is very high.
We have enjoyed ruxolitinib, we have approved JAK2 inhibitor. What do you think the risk management in such country with no available anti-JAK2 and those patients with baseline 50 platelet count? What do you think the risk management in such patients?
You mean those with platelets below 100, right?
Below 50.
Below 50. Off the record. Yes, I know. This is again a challenge. of the record. Officially, we are allowed, at least in Europe, until 50 with ruxolitinib. But to be honest, I have already treated patients with even transfusion-dependent thrombocytopenia if I don't have other options. Because we know one reason for the thrombocytopenia is the very big spleen, hypersplenism. And indeed, what you see sometimes, especially in the first few weeks, the spleen gets smaller and the platelets rise up. Very interesting. Again, off the record, there are no big data. What is very helpful is a low-dose ruxolitinib in these patients combined with thalidomide. I don't know whether you have thalidomide available.
Yes.
Thalidomide raises the platelets and the hemoglobin, and you could even start treating the patients very regularly with ruxolitinib. So thalidomide plus rux. And I'm actually treating now at the present time several such patients.
And do you think what's the next management in those patients who are very young and need transplant? Do you send them to transplant upfront, or you start with pediatric?
We never transplant upfront unless we have high risk and no spleen. We always try to use a JAK inhibitor. And as I said, I don't send people automatically nowadays to transplant if they are stable and are doing well.
Even those with high risk?
Even if they are high risk, because I have shown you the survival data. And indeed, comfort trials were only patients with intermediate to and high risk. And I still have 1/3 of the patients, 2009, we have now 14 years, doing perfectly well. And these were candidates for transplant. So, no.
Yeah. Thank you very much. You're not sending your patient. I can't say you're biased because you're not doing the transplant. But look, if you're looking on the survival data on the long run, the comfort 2, 1/3 are surviving. But if you look on the transplant data, in the case when you're having cyclic match-related donor in a good performance patient with a low comorbidity index, probably you can have 50%, 55% of patients are surviving. Though there is no head-to-head comparison, I agree. But I mean, doubling the number of patients, doubling the number or doubling the survival time in those who get cyclic match-related at least transplant. Would you comment on this? Thank you.
Definitely, as I told you, younger patients, I have no issue with transplant at all. Comfort 2 survival or Comfort 1 survival, median survival after 5 years, the median age of the patient population was 67 years, was more than 50%. After 5 years, 50%. Transplant data, survival again, we have 50% after 5 years, but the median age of the patients is 1 decade less than the patients treated with ruxolitinib. So it is a challenge. I fully agree, and I repeat. And I use the MTSS score, to assess the risk of transplant-associated mortality. This is a very helpful risk, and just the presence of a JAK2 mutation is 1 point. An age above 57 points is 2 points. You know that. The availability or not availability of a fully matched HLA donor, again, is an issue. And the presence of ASXL1 mutation, again, is a negative prognostic factor. So really, I always discuss with, transplant-eligible patients, I always try to weigh the risk and benefit. And we assess and we discuss, because I myself do the indications for transplant. I do take care of patients post-transplant. I work very closely with my transplant colleague, and we discuss every case really and weigh risk-benefit. I told you, it is not an easy decision, but I don't take patients just because of age of transplant.
Yeah, I agree. I agree with you. It's a difficult question. Yeah. with the availability of all of these agents, probably.
It
Yes,
becomes
in a
more
country,
difficult, yeah.
but in a country in Jordan with no available medication, with the, for example, what suggested by the chair, I mean, with the low platelets, probably the transplant will be the.
Yes, right.
Thank you very much.
Thank you.
شكرا للدكتورة هيبة وشكرا للجميع وبعد we close this session. Thank you.
شكرا جزيلا. Thank you very much. مع السلامة.
We have a slight change on our program. Actually, the multiple myeloma Johnson Symposium lecture will be postponed till 7:30, and now we have a break for 40 minutes, and then we'll write the long symposium. So we have a break now for 40 minutes.
Hello, do you hear me? Hello? Unfortunately, I cannot hear you. Do you hear me? Just say yes or no. Hmm. Okay. So you, when I have to start, I cannot hear you, unfortunately. Now I hear you perfectly. Super.
I would like to present you for our Dr. Hochmeyer is the leading the respiratory oncology unit. Critical care medicine at Clinic Floridsdorf. Dr. Hochmeyer also is a lecturer at the Sigmund Freud. He is the author and co-author of more than 270 published book chapters, reviews in journal involving thoracic oncology. He's in various clinical trials in lung cancer. And we're pleased to have him with us, and he will talk to us about recent updates in the management of advanced best of 2022. The floor is yours.
Thank you, colleagues. Thank you very much for the nice invitation. I'm happy to be with you today. And as a director of what you want, your pronunciation of Floridsdorf is perfect. Florida, but it's not Florida, it's close to the Danube. Thank you very much. To cover all the topics. I would love to be in Jordan at this time. The traveling, and I have 4 children at home. My wife is not leaving me at home. So we'll try my best to cover all the important topics in this situation about the recent updates. There were so many things, but I will put it in the situation. I started to work with lung cancer in the 20s, and I didn't choose lung cancer. My chief told me nobody wants to treat lung cancer. Please treat these patients. And then I said, okay, I like medicine, and it was very simple and very just more only. Nowadays, we know that lung cancer is not lung cancer. We field of immunotherapy and on the field of driver mutations, a lot of developed situation. So we can say lung cancer is not lung cancer anymore. We have treatment options for our patients in this situation. So we choose between immunotherapy plus chemotherapy, or targeted therapy. So this is the today development in future are the bispecific antibodies that we in different antibodies, for example, PD-1 plus anti-TIGIT, PD-1 different targeting different receptors with antibody who is covering both sides. One antibody is already amivantamab for insertion 20, a very rare indication, but here we are dealing already with bispecific antibodies. The other group are the anti-drug conjugate, working already with trastuzumab deruxtecan, a lot of wordings where we have always an antibody with a toxin combination, administering a targeted chemotherapy, something like that. A lot of colleagues initially said, why do we need to test patients with non-small cell lung cancer? We don't find so often something. This is a recent publication where you see when we test with NGS, a lot of patients target. When we look at the Western population or even Asian population, have no target that we find in the situation. A lot of patients have ALK, MET, RET, and there are some rarer mutations, but when we put also together, we have also a lot of mutations in this setting. There are also mutations that are not druggable, for example, KRAS G12 target. On the other hand, KRAS others, not KRAS G12C, is a druggable target. On the other hand, we also rebiopsy patients. Mechanism much better in this situation. These are data from our LaLuca registry where we are testing about 400 patients in a half a year. We just look at the NGS reports, and you see more than 50% of that is relevant for our patients in this setting. For colleagues who are not treating so many lung cancer patients, sometimes have so many labels based on ALK, ROS, NTRK, RET, BRAF on the targets, and nearly all 2 months a new launch of a new drug patients in this setting. These are available drugs in our center on studies based on labels. Here in a little bit lighter green, investigational compounds. On the other hand, on the use crizotinib, ceritinib, alectinib, brigatinib, lorlatinib, ensartinib, or repotrectinib. That is 2% of our patients. So it's getting really more and more interesting. So it's important that we test and decide which patient needs in this situation. So when you treat patients in the right way, they're living longer. Test them. When you don't test and don't treat them, the survival can be not. So this is our treatment algorithm, how in our center, our patients. So we're trying to test patients. Patients receive a targeted therapy, EGFR, ALK, ROS1, NTRK, RET, MET, and also for HER2 mutations, we're treating these patients with targeted therapy. If they're progressing, we try to do rebiopsies, and then we try to include also chemo IO in this situation. Not progressing, when they have no driver mutation, we are mainly treating patients immunotherapy alone or immunotherapy plus chemotherapy by 50. Measurements are the most relevant treatments for these patients. So we, for example, 190, 80% PD-L1 staining without upfront. Advantage is also here we can treat patients with 400 milligrams in the schedule, what is for a lot of patients very convenient. The mass is higher, patient is refusing chemotherapy or PD-L1 is less, then we combine chemo and IO. Keynote 407 and Keynote 189. PD-L1 negative are receiving also mainly immunotherapy plus chemotherapy. When the patient is progressing, then here platinum-based chemotherapy, and then we're adding in KRAS G12C, sotorasib in this indication. So when I compare it to the past, it's much more options and much more possibilities for our patients. What do we know about immunotherapy and EGFR mutated patients? Is extremely poor. On the other hand, we published a case for EGFR mutation who received osimertinib in an EGFR mutation with L858 found patient on pembrolizumab and he responded. So this is not generally for patients, but not all targets, druggable targets are. We know BRAF, MET, KRAS2. It seems that these patients are responding quite well also to chemo IO in this situation. Personal experience seems that they are not responding to immunotherapy alone and I recommend therefore a targeted therapy mainly for EGFR ALK RET-1, but we don't have enough data to recommend the right strategy in first line, but they receive anyhow the targeted therapy in this situation. The sequencing for some drugs is relevant. For here data from patients receiving selpercatinib, prior immunotherapy or no prior immunotherapy. We know patients with RET fusion not respond quite well to immuno or immunochemotherapy, and when we treat before with immunotherapy, the serious adverse events are higher, doubled in comparison to no immunotherapy. So for targeted therapy, the sequencing is relevant. On the other hand, when we know the targeted therapy is working better, we should use it first line. When we know example for sotorasib is leading after to more liver enzyme elevation, but sotorasib is not working in first line clearly better in comparison to immunochemotherapy. So I would not recommend to start here. The sequencing makes sense. You cannot do it cannot deal it in another way. Skipping mutation, we had a recent publication where we collected 100 patients from center with MET14 skipping mutation, and you see these patients are responding quite well to the MET inhibitor, but they also can respond to immunochemotherapy, but normally these patients are frailer. Here I recommend to choose between immunotherapy and the MET inhibitor in this situation. This is just an example progressing on osimertinib after 7 months of 5 months, sorry, and the patient progressed, and we found in the liquid biopsy amplification, and we saw at the ESMO when patients receive with a MET amplification in the liquid biopsy that these patients can also receive osimertinib plus tepotinib when, and we're doing that when patients are refused chemotherapy or chemo IO in this situation. And this is also a ending that when we do rebiopsies in a targeted therapy strategy, we sometimes find new possibilities for our patients. Also, patient, a very rare indication, HER2 mutation receiving chemo IO, here for 9 months chemotherapy plus pembro in a HER2 insertion 20, and then the patient progressed and then received trastuzumab deruxtecan and with a nice remission in the moment. For TDX, I didn't sequencing immunotherapy, and then TDX is not leading to more prominent or relevant side effects. Now I'm focusing more on patients without a druggable target in this situation. This is a 62-year-old patient, PD-L1 staining 1%, biomarker negative. You see a huge tumor load here on the left side with collateral lymph nodes, and normally you would say this is a very aggressive tumor. We cannot really treat this patient perfectly. What would be your recommendation? PD-L1 negative, stage 4. We have different options in this situation. We can go for the keynote regimens. We can go for the IMpower 50 regimens. We can go for the Checkmate 9LA, Checkmate 27, or other possibilities. So we treated this patient, and this is standard of care that we go for mainly carboplatin, pemetrexed, pembrolizumab, saw now already for 21 months extremely good remission. What we see a lot of times now that the remission rate is clearly higher, and we didn't. Should we also do radiotherapy now for this patient with this astonishing? You see here the tumor was so huge that he pressed the mediastinum the other side, and now with the tumor shrinkage, the mediastinum even went to the left side. So this is really astonishing how sometimes responding. For sure, it's not always like that. This is clear, but we see much more often that the remission and improvement is better. We published in JCO the update of the Keynote 189 trial, and we want to highlight here that just get a question on the on WebEx. Therefore, I was a little bit here you see the Keynote 189 trial, and you see that it from hope I cannot move forward. Check. I have to see how I can manage. Yeah, now. So what is important for the Keynote 189 trial? You see here patients with no druggable target, EGFR patient received chemo IO, and what was important that a crossover is allowed. In the checkmate 227, checkmate for 9LA or other studies was not allowed. So when you're looking at the overall survival data, you have to be aware the rate of immunotherapy in second line was clearly lower. And when we look here, the checkmate 189, 57% of the patients crossed over, less than 30%. So when we compare overall survival data in hazard ratio, this is not correct in this situation. And we saw the overall survival data with 2 times higher overall survival, even crossover was allowed. Really astonishing and clinically meaningful data for our patients. And we see it in patients above 50, 109%, or lower patients. So it's the clear standard here in the situation. Therefore, JCO accepted the 5-year-old update for our patients in this situation. It's also important that the remission rate is clearly higher. You have a 3 times higher remission rate. Why is it so meaningful? When we want to move on to the treatments and see we are doubling or 3 times higher in the remission rate, we have these drugs in the early stages also. Because I'm a little bit, I have to spare time in this situation. We also know liver metastasis and brain mets is a very important topic, and we have if these patients do also respond quite well, and we see that liver metastasis and immunotherapy is not leading to a worse outcome. We see even a clearly better outcome for patients with liver metastasis. And just an example from the Keynote 118, you see a patient from 2017 where we included this patient 2017 in the study, huge axillary lymph nodes, liver metastasis, T4, T3, N2, M1C, and we in the trial, and you see the patient is still alive. After 6 years, the axillary lymph nodes are still completely under control. Also, liver metastasis completely disappeared, and the patient is still coming to the follow-up and asking me, what is my position? What is going on? Still a metastatic stage 4 patient. My prognosis, and I cannot tell the patient what is the prognosis because the patient is still alive after 6 years, where we know that some patients can, and this is now a survival. I can just say in the moment everything is fine for you. Also the same for brain mets. The drugs are also working quite well. Pembro plus chemo is working in the brain, so brain mets are also responding quite well in this situation. Here just an example, the 12-week follow-up for a patient with without treatment in the brain because it was asymptomatic and we wanted to see how is the remission situation. What we don't know is what should we do with the steroids? Is how should we deal patients who are needing steroids? Is a publication also from JCO where we saw that we should keep steroids as low as possible. Patients who need a higher dosing of steroids is the outcome worse. Also from a recent publication here, patients who received initially more than 10 milligrams cortisone, the outcome worse. So we should avoid too higher steroids in the beginning of the treatment. The patient needs steroids during the treatment. This does not influence the outcome of the patient. When you need it based on side effects, immune-related adverse events, the outcome is worse in this situation. Coming now to the biomarker negative patients. Here, initially, we didn't know what is the strategy for these patients. Here we see a patient with a fluidopneumothorax based on a malign pleural effusion. A fluidopneumothorax, normally you see here the drainage, a very situation for the patient. And we started also here with the keynote 189, and you see a complete remission also of the lungs that lead a complete expansion of the lung again. And this is really astonishing. Normally, some of these patients is clearly worse. The patient is now 1 year in treatment already. Also here, a patient PD-L1 negative, biomarker negative since a long time on treatment. Here the patient is since 2019 on treatment. Normally, we stop the treatment after 2 years. Patient is still in remission in this situation. Also here, patient with a squamous cell carcinoma patient receiving an PD-L1 staining 20 ml with keynote 407 regimen, a clear better improvement. Huge tumor here on the left side infiltrating the aorta. Also the contralateral metastasis on the other side in complete remission in this situation. This is something before 20 years ago, I was dreaming of something like that situation, and nowadays we are able to administer these patients and give them hope in this situation. We also received an update to the keynote 400 squamous cell carcinoma patients. Also here in the study, the important issue about the allowed crossover. What is important when we compare keynote 407 to a checkmate 9LA, where crossover was not allowed and only a few patients received immunotherapy in this situation. And you see here in the control arm, more than 50% were allowed to cross over in this situation. Well balanced. And you see also here in the overall, in the 5 years overall survival, doubled overall, even crossover was allowed. So really clear data, separation of the curves, clear data for all groups in this situation. The group here, the keynote, the PD-L1 staining negative ones, but also here I have to announce even crossover was allowed. The outcome of the patients is a clear trend. PD-L1 negative positive patients. PFS also clearly in favor in this situation, and also the remission rates. What is important that we have to highlight is in the neoadjuvant setting for our patients in this setting. As to keep the time, and here you can see also a patient receiving 3 years. I think this patient, yeah, I wrote it down, since 3 years, this nice patient with a squamous cell carcinoma, heavy smoker, huge tumor load here on the left side, leading to a complete remission with the keynote 407 regimen. We stopped the treatment after 2 years, and the patient is still is still in remission since 3 years. We also saw at the WCC an update of studies, keynote keynote 189 and keynote 407 to collect data for PD-L1 patients. And you see here a lot of patients were collected, 408 patients, PD-L1 negative patients. Crossover was in all studies, and you see I can skip that, but the overall survival for all patients, PD-L1 negative patients, was clearly in favor for all patients. And when we go into the waterfall plots and the you see here also for patients with histology, squamous cell carcinoma, PD-L1 negative, they are all in favor for the Keynote 407. Even crossover was allowed. So a clear sign for us, PFS, to use this regimen for our patients, and it's the gold standard also for carcinoma patients in this situation. Remission rates clearly in favor. I try to keep the time, and here also the updated OS in favor also for the squamous cell carcinoma, and I can say from our center, Keynote, and also for the squamous cell carcinoma patients, PD-L1 negative, clearly based on this is the right strategy. I skip it to keep the time and give in some practical issues. Here's a patient, 81-year-old male, PEC years. You see here T4N3, M1B with an bone metastasis. And what we are always asking in this patient, the patient has pain with radiotherapy first and then doing chemo IO. Should we go to chemo, radiotherapy and IO plus chemo? How should we do it? Is it allowed to combine it? And this is the question we had in our tumor board, radiotherapy plus pembro alone. Let's see what is going on. And our experience in giving pembro and radiotherapy in combination is always a good strategy and is improving outcome of our patients in this situation. And here you see the outcome for pembro and radiotherapy. No pneumonitis happened, and the patient received just radiotherapy of the bone. But here the lesion, the cavity right side, showed a very good remission in this situation, and also the bone metastasis showing a very good remission in this situation. Time, I think I have 10 minutes left. When it's right, just check. Okay, I was told I have another 20 minutes left. I only want to show you the Keynote 24 trial. Keynote 24 trial was comparing pembro against chemo and allowing crossover. And you see after 5 years, still 35.8% of the patients after 4 years, and 1/3 of the patients still alive in a stage 4 situation. Even crossover allowed, the ratio is astonishing, and this is really a very motivating result in this situation. Also PFS clearly better, but we see also a pseudo progression. So looking at the PFS data is not always very easy to interpret PFS. So OS is always the. Here's just an example from January 2016, where we put one patient in the Keynote 24 trial. The patient received pembrolizumab in the second. Initially, patient received carboplatin pemetrexed, and the patient had no relevant comorbidities. You see a huge hilar lymph node here, the primum, and also here metastasis. We started the treatment, and after 1 month of treatment, exploded. You see the liver metastasis 2 times higher than it was before. New pleural effusions, new lesion here on the left. And I remember my chief, he was nearly killing me in the morning discussion and said, Max, with our patients, the patient is feeling worse, so you have a symptomatic progression. And I also said, perhaps it's a hyperprogression. And at this time, I did so much about pseudoprogression, but I was hoping that the patient can also have a pseudoprogression in the situation. We did a pleural puncture in this situation, and we found cells in the pleural effusion, which were high PD-L1 positive. You can see here. So I was hoping for the patient that it's a pseudo-progression, and we continued to the treatment. And then we saw after another month of treatment that the pleural effusion was regressive. This was clear because we did a pleural puncture, but lesion on the left side and the liver metastasis went down. And when the CT scan 2.5 years later, you see here nearly complete of the liver metastasis, and this was a symptomatic pseudoprogression. We published this time 2 cases of symptomatic pseudoprogression. With immunotherapy alone, we've seen about 20% of the patients a pseudoprogression, and symptomatic pseudoprogression in about 3 till 4%. With chemotherapy, the pseudoprogression is relatively rare. Sometimes we saw it sarcoid-like reaction that after 6 weeks, when we did a biopsy in the lymph nodes, sometimes a sarcoid-like reaction, but it's not so often phenomenon when we combine chemo IO. What is an important question for the neoadjuvant strategies of chemo, that we perhaps can see a progression after 6-9 months, also with 6 to 9 weeks. So I would say chemotherapy and IO be administered for 3 months, and then doing also here a restaging. When you do it, it can be critical in the interpretation. So at the end, I don't know which patient can have a hyperprogression or a pseudoprogression, but rebiopsy is also difficult to understand the rebiopsy, but you have to think about it. And when somebody is receiving immunotherapy alone, perhaps when you're not sure, adding here also in this situation. Here's a patient who had an autoimmunal disease, because this is also a patient where it's difficult to interpret the data. You see here a 6 female patient, COPD2, Hashimoto thyroiditis controlled with thorough treatment, and you see here smoking history. The patient had metastasis and a huge tumor here on the left side with lymph node involvement. The guidelines, or also from the data we have, is that autoimmunal disease patients were excluded in the trials. So written down that we should know that we should deal these patients with caution, but no, is it allowed or not? So therefore, I took this patient example. The patient had a T4N3 M1C, insertion 20 HER2 mutation, PD-L1 staining negative. So we don't know targeted therapy for HER2. Is that chemo IO works quite well in this patient, and trastuzumab, the second line, is not leading to more pneumonitis. So we have as long as we out of the data, first line trastuzumab deruxtecan against chemo IO, it's still IO as the standard for these patients. But also the Hashimoto thyroiditis is a little bit difficult, but we knew that when the autoimmunal disease is controlled, it's allowed to start with immunotherapy in these patients. So we discussed therapy, chemotherapy, chemo plus IO, or something else, and we went for carboplatin pemetrexed for this patient. The patient is still months under treatment. You see here a very good remission of the liver metastasis and also the tumor. For sure, it is not lasting that long. From my experience, these patients will have a recurrence normally in the time of 6 till 12 months. We can add here also the targeted therapy in this patient group. But the data about autoimmunal disease and immunotherapy, there's one work, JCO, in this setting, where they saw that when the patient has a autoimmunal disease, the exacerbation of the immunotherapy disease is a rare phenomenon. So the efficacy is quite comparable with other populations. 2019, we saw a FDA presentation from where patients were collected autoimmunal disease and lung cancer and received inhibitors, checkpoint inhibitors. And you see here 500 patients compared to 1,800 patients, And the outcome in OS is similar, patients having autoimmunal disease and receiving immunotherapy. And this is leading to the also for the evidence of autoimmunal disease. So patients receiving immunotherapy with the evidence of an autoimmunal disease and therapy is not leading to more to an exacerbation of the autoimmunal disease. And I had also some patients where it was a paranoia that these patients had an autoimmunal disease based on the tumor. When we treated the tumor, the response was good, and also the symptoms of autoimmunal disease improved. I'm moving now a little bit to the strategies, and you can see here a patient who had is 49 years old, morbus Parkinson, performance status is good. Lung function, you see here a tumor with T4, tumor size and infiltrating the mediastinum, huge tumor, and also two disease. At least N2, we found a squamous cell carcinoma, PD-L1 staining %, a staging in the PET-CT N2 till N3, but I would say it's an N2 disease because we did EBUS in the PET-CT, it was an N3. We said for the radiotherapy, it's too big. For surgery, it's no indication. That let's go for a local advanced disease for chemo IO in this patient. And you see a very nice remission. You see the tumor reduced clearly, but it's a partial remission based on the CT scan. Also here, the CT scan follow-up of the lymph nodes, a good remission, but based on the area. It was a partial remission. When I showed the patient in our board, we said this is possible to do surgery, even the patient had a T4 and 3 disease. And we did surgery, lobectomy of the left lobe, and we saw a T0, N0, R0 situation, a pathological remission in 2020. And the patient is still in remission. And it was only the discussion then, should we could go on with pembrolizumab for another year in this situation, and then we stopped, and the patient is in the moment with the situation. And out of this experience, we are treating patients in this situation already with this strategy, and the strategy will work quite well for our patients in this situation. Be aware is the side effects, and some patients can have a pneumonitis that we published based on our wrong decision. This is a patient with a tumor here on the right side, brain metastasis. And you see, we started with the treatment with pembrolizumab in 2000. And the tumor response was quite well. What the patient developed, new lesions here on the left side. You see here the bronchiolos, and around there, something like crazy paving. Also here, a positive arrow sign. In the moment, I didn't know how to handle the situation. I didn't want to give cortisone because I was afraid that this can lead to a worse outcome. And the patient went on a travel and came back after 6 weeks, and we stopped pembrolizumab, but I didn't give cortisone in this situation. And 6 weeks later, the patient came back. 8 weeks after the first CT scan, the patient died on the intensive care unit. I showed you initially a lot of good cases. Here, I showed you a case where I did a wrong decision. I should have given already here of the pneumonitis already a cortisone to avoid this heavily developing pneumonitis. The patient who had an autopsy in this situation, and there was no tumor found anymore in the brain. There was no tumor found in the lungs, but unfortunately, the pneumonitis was leading to the death situation. And when I see nowadays a pneumonitis, I start relatively cortisone to avoid the pneumonitis, and when it completely resolves, I restart the immunotherapy also when it's possible. We know that patients have immune-related adverse events, the green line, having a better outcome. So it's motivating the patient when they have immune-related adverse events that the outcome of these patients is better. When I see lesions like that with an arrow sign, with something like that, I stop immunotherapy, start with cortisone, and then when you give cortisone, like this lesion here is leading to a complete remission, then you can start with this situation. In the near future, we will see a lot of combination treatments in combination surgery, radiotherapy, targeted therapy, a lot of options. And at the end, my nearly last slide, you see the treatment is getting more complex, but all these strategies that we are doing now will come also to early stages, and we're using it like in this case I presented the keynote regimens also in locally advanced stages. We have the approval of Adaura with osimertinib in the adjuvant setting. Also targeted therapies moving into the early stages, but generally no driver pembro plus chemo, or PD-L1 negative ones or less than, we're giving chemo, or in targeted therapy options, we're giving targeted therapy. Dankeschön from the Clinic Floridsdorf, and to the nice chairman who could anytime work in our center.
Thank you, Dr. Hoshman, for this great discussion. I would like to ask you a question. I need to elaborate more on the use of steroids with immunotherapy. We generally have the idea that using steroids with immunotherapy makes the outcome worse. What's your opinion on this?
So there are two different groups. I just turn on my light. You can see me properly. There are two different types of patients receiving steroids. Steroids can be given initially because the patient fatigues, UPD, brain mets, etc., or patients need cortisone based on immune-related adverse events. For cortisone receiving during the treatment, this is not leading to a worse outcome. This is, you can start cortisone, it will improve, and when you have a complete remission of the immune-related adverse event, you can or even restart immunotherapy. On the other hand, when you have cortisone already in need of the treatment based on brain mets, you should try to keep it lower than 10 milligram prednisolone, because then the outcome is not worse. But the higher, and some we are using higher dosages based on our, we need more or less, but when you keep it lower than 10, the outcome is not worsening.
Dr. Maxwell, a lot of patients who have autoimmune disease, we need sometimes to use higher doses.
Try to keep the dosage as low as possible. Normally for the rheumatitis, we have patients with 5 or 10 milligrams of prednisolone, and then we can start patients who could reduce cortisone completely, because autoimmune disease that was driven by paraneoplastic by the tumor got better because the tumor was remission, and then it was very. On the other hand, this is not always. Sometimes the arthritis stayed, and then I had to keep the cortisone on this level. The only problem is also when you have then side effects, it's harder to deal the side effects. How much cortisone do you have to give then? And this is sometimes an individual strategy you have to solve.
Dr. Max, another question, please.
May I ask you, if you have two driver mutation in the same patient, have you had experience using two inhibitors?
Actually,
and combination ROS or MET or MEC, whatever.
So there are two different types of compound mutations. There we have compound mutation that gets during a targeted therapy pre-treatment. For example, we had a patient running on ALK. He received brigatinib and alectinib. Then he reproduced a red fusion ALK. Then we put the patient on lorlatinib and selpercatinib. Then had a compound mutation as a resistance gene. Then I tried to cover botinib and osimertinib in MET amplificated patients. But this strategy, especially in EGFR on ALK, this is an extremely rare phenomenon that we see really a lot of compound mutation resistance that we can really treat. The others are mainly patients have KRAS mutation plus another mutation, and we know KRAS mutation is normally a gene. And these patients, when I have a patient KRAS plus red, KRAS plus something else, then I go normally for immunochemotherapy in this situation because the targeted therapy not work with this resistance mutation quite well. On the other hand, look to patients from the older testing, when we did ALK testing or with immunohistochemical staining or just a point mutation testing, very often saw patients that had actually not tested perfectly. ROS1 with immunohistochemical staining is not positive. We need NGS to approve it. And for targeted therapy and deciding which mutation is there, I only go for NGS. But it's a rare phenomenon that you have ALK and ROS, for example. This I saw once in my life in about 4,000 tested patients.
Any question? Dr. Charles.
Thank you, Professor, for a very comprehensive talk. I'm not saying that there's a patient, but I'm taking care of the informal patients. I'm regarding pseudoprogression and hyperprogression. So if you go by the guide, it's scan, hyperprogression, it should be symptomatic at the end. But you look or publish in cases where the hyperprogression and symptomatic, you can get a therapy. So at least from the informal point of view and the clinic guidelines, I think we're not continuing therapy in case of symptomatic hyperprogression. And sometimes even without symptoms, to differentiate. I know. In such cases, probably you may go and do a biopsy. Most of the time, you can't do a biopsy. I don't know. It's different, for example, or is it just institutional policies? Thank you.
Thank you very much for your comment. And it's really, I see it from the field. This is also tricky. A lot of times I have to answer. When we go for rebiopsy in this pseudoprogressive, really helpful is only the sarcoid-like reaction. When we see the sarcoid-like reaction, we feel safe and say this is a pseudoprogression. But when you still find tumor, we don't know if it's hyperprogression or not. The patient I showed you, and this case report I showed you with 2 cases, this was citated more than 100 times already, because your question you said, or your comment, is clearly we have, and don't have the clue. We have to decide always individually. When you do immunotherapy alone, I normally go for immuno and adding then chemo. We also, and I didn't show the trial now, we had also the trial where we had pembrolizumab, and in the time of the progression, we added ramucirumab and drug. This is something you can also think about, that you are adding an antiogenic drug, want to improve the response in the situation. So this is something, adding chemo, adding ramucirumab in this situation to improve the outcome for these patients. But I don't have the clear clue, and for the publication was so well tolerated because symptomatic progression, we say we have to stop the treatment immediately. This is progression, but therapy, it's different.
Dr. Roshmeyer, I have experience with a patient who had underwent liver transplant from sclerosing cholangitis, which is autoimmune disease, and he developed lung cancer. So I gave him Keytruda, and like for 3 months he was tolerating treatment very well. If you have any such experience with the transplanted liver.
This is no, this is something I sent to the transplant, but only had a kidney transplant. The patient died relatively early, but you should publish this case because in literature, I think there are 4 cases or something like that. Extremely rare situation. So please, because we have to learn from your side. Thank you very much. It's important.
Thank you. Okay, thank you, Professor Hochmeyer. We now move to our next lecturer. Thank you, sir. يلا سكر.
Bismillah. Welcome, Dr. Maria. Thank you for joining us. Dr. Matthews, can you hear us? Dr. Matthews. Dr. Matthews, can you hear us? Okay. Dr. Matthews, I think you are muted. You are muted. Dr. Matthews, if you hear us, please log off and rejoin again. We can't hear you. Can't hear your voice.
هي من عندها معناها تكون مسك التليفون او ساكن ما تكونش معطي مرات تكونش معطي ليش يعني مش موافق على استخدام هي عم ممكن يعني وجه مرات
So we can you try again, Dr. Matthews? We can't hear you.
Okay, I am going to rejoin again.
That's great. Now we can hear you.
Okay. Now can you hear me?
Perfect. Yes.
Okay, perfect.
Very nice voice.
Okay, very much.
This is really my privilege. I'm honored to introduce Dr. Maria Matthews. She's well known in the myeloma community. She's the head of myeloma and clinical trial unit at the department and professor of medicine at the University of Salamanca, Spain. She's
the coordinator of the Spanish myeloma group, and she has a direct involvement in the trial design, enrollment, and development. She has more than 350 publications in a high index journal, and she's a member of International Myeloma Working Group as well as International Myeloma Society, IHA, ASH, and the Scientific Committee of ASCO. Awarded several awards. I can see here in her CV the Brian Urey Award in 2019, Neurology Award in 2022 as a recognition for her excellence in myeloma research. She will be the president of the Society of Hematology. I think he was appointed for that position, and she will serve as president for years. Dr. Matthews will give us a talk about the frontline usage of daratumumab in multiple myeloma. This is really a great honor for us, and the floor is yours. Please.
Yeah, so first of all, thank you very much for the invitation, and I hope you can see my presentation.
Yeah, we can
okay.
see.
Perfect. And well, thank you very much for the kind introduction. And as you said, I will talk about the role of daratumumab as part of the first line of therapy in myeloma, and I would like to acknowledge also to Janssen for the invitation. See the conflict of interest, and something I would like to remark before entering into the discussion on how newly diagnosed myeloma patient, and it is about the treatment goal we can plan when we have in front of us newly diagnosed myeloma patients. It's true that with the introduction of the novel combinations, the survival of myeloma becoming much more long than in the past, and indeed, I think that the maybe can be a realistic objective for some patients to try to generate surrogate markers for long-term survival or even for cure. And you know that the eradication, or at least the major reduction of the tumor, is something required. And in line with this, you probably know how the measurable disease and the undetectable measurable residual disease is maybe a powerful prognostic factor predicting outcomes in patients with multiple myeloma. And this is applicable to newly diagnosed myeloma, but also to relapsed and unrefractory myeloma. This slide makes a reference to the minimal evaluation in the bone marrow, but now we have optimal techniques like PET-CT in order to evaluate also the measurable residual disease inside of the bone marrow. And we have to incorporate the PET-CT in order to evaluate our patients are in complete metabolic response, and the final objective would reach complete metabolic response as minimal residual disease in the bone case by flow cytometry. But the final objective is when we look in patients with double negativity for measurable residual disease, the outcome is better. However, I would like to pay your attention to the fact that in this graph, free survival, patients with the minimal residual disease negative inside and outside, there are some patients who finally relapse. And I think that this opens the door in order to investigate more in the minimal residual disease evaluation. And we have maybe to investigate more on the sensitivity threshold and 10 to the minus 6, because you can see here in this meta-analysis how when is 10 to the minus 6, the number of patients in MRD negative is lower, diagnostic value is stronger. And the other important point is the achievement of undetectable measurable residual disease and sustained over time. And again, are the same exercise, less patients are able to maintain the minimal disease as negative, but the prognostic value is stronger, and we have already information coming from these two phase 3 clinical studies conducted in myeloma, newly diagnosed, transplant ineligible, but I would like you to focus on the analysis and patients in which the minimal residual disease was negative obtained over time, in this case at 6 months, but the same graph is obtained. Detectable measurable residual disease sustained for 1 year, the prognosis and the progression survival is significantly longer. And I think that this is relevant because if this is what we want for our newly diagnosed myeloma patients, it is very have to utilize the best combinations as part of the first line of therapy, because based on this analysis, and there is another similar analysis conducted in years ago, we are going to lose approximately 1/3 of the patients between the first and the second line of therapy. And this is applicable to the transplant eligible and to the transplant ineligible. So these high attrition rates underscore the need to use the treatment regimes up front better than reserving them for subsequent lines of therapy, because the benefit is going to decrease, and in addition we are going to benefit to less patients because we are going to lose patients between the first and the second and the third, and so on. And once we've seen this, how to manage newly diagnosed myeloma patients. If we consider that the patient is transplant eligible, here you can see the European guidelines published in 2017 and in 2021. And the starting point is going to be bortezomib, thalidomide, and dexamethasone. I decided to put here this slide because you can see here two phase 3 clinical studies conducted in 2005. This means that the follow-up for these two phase 3 clinical studies is longer than 10 years. But if we focus on VTD in the Italian study, VTD in the Spanish study, with more than 10 years of follow-up, the median progression-free survival is between 52 and 60 months, and at 10 years, more than 50% of the patients remain alive. These data are good data from my point of view, and these data represent the starting point in order to improve. And the optimal way in order to improve VTD is by the addition of the monoclonal antibodies anti-CD38. And in the first line of therapy, you know that daratumumab is the monoclonal antibody we can incorporate to the different standard of cares. Why daratumumab added to the different standard of care is going to add a significant benefit. We are going to see the results we have coming from the phase 3 clinical studies, but this is also in relation with the mechanism of action. You know that daratumumab targets CD38 expressed on the surface of the plasma cells, and the complement cascade is going to be activated, as well as the antibody-dependent cell cytotoxicity, the phagocytosis, and the apoptosis. This means that there is going to be a direct anti-tumor activity. But you know that the T-rex, the B-rex, myeloid-derived suppressor cells also do express CD38. After the treatment with this monoclonal antibody, we are going to observe a depletion of CD38 positive immunosuppressive cells. And at the end, what we are going to see is an increase in CD8 positive T lymphocytes able to contribute to kill myeloma cells, but in addition, to exert an immunomodulatory effect, and this immunomodulatory effect do contribute to deep and durable responses. And I personally consider that these two mechanisms of action are the main rationale for the great data we see when we add the monoclonal antibody anti-CD38, in this case daratumumab, to whatever standard of care. The first example is bortezomib, thalidomide, and dexamethasone plus daratumumab, evaluated in the phase 3 Cassiopeia study. And this study included over 1,000 newly diagnosed myeloma patients, and Dara VTD induction transplant, Dara VTD consolidation was compared with VTD transplant and VTD. And this was the part 1 of the study, and this does include the primary endpoint of the study. When we added the monoclonal antibody anti-CD38, you can see how after consolidation, the rates of complete response rate or better are significantly higher, and over 70% of the patients are able to achieve complete response. But what about minimal residual disease negative? Again, you can see how approximately 60% of the patients are in MRD negative. And this finally translated into a benefit in progression-free survival. I would like to remark how VTD, the control arm, resulted in a median progression-free survival of 52 months, that it is exactly the median progression-free survival we've seen in one of the previous phase 3 clinical studies with a very long follow-up. So this means that this study does reproduce the control arm, and when we add daratumumab, we are going to increase the median progression-free survival. It has not been reached yet, and there is a trend towards also a benefit in overall survival. But if we remember my first slides focusing on the importance of undetectable measurable residual disease and sustained over time, this is what we've seen also in the Cassiopeia study. More patients achieved MRD negative, more patients are able to sustain it as negative over time. But here you can see the progression-free survival for those patients in which the MRD was negative and maintained over time. The progression-free survival curves are like flat. So I think that this is an important surrogate marker, and we should fix this as our primary objective in the treatment of patients with multiple myeloma. Toxicity, of course, is also important. The addition of daratumumab, in this case to VTD, really did not result in much more toxicity. It's true that the incidence of neutropenia was a bit higher, but in terms of peripheral neuropathy, you can see here how the addition of daratumumab did not result in more peripheral neuropathy. From the peripheral neuropathy point of view, actually, the risk factors associated with higher cumulative incidence of peripheral neuropathy were to have peripheral neuropathy at least grade 1 at baseline, as well as a higher body mass index. But in principle, the presence of the identification of peripheral neuropathy didn't impact into the efficacy of dara-VTD. In terms of other non-hematological adverse events, the infections were slightly higher in dara-VTD, but not very much, because, as you know here, dara-VTD was used as part of the induction and as well as part of the consolidation. Infusion-related reactions occur in approximately 1/3 of the patients, but here daratumumab was given IV, and now it is possible to use it as subcutaneous formulation, and the incidence will significantly decrease. Is there any impact in the peripheral blood in the stem cell collection? And in principle, the answer is no. You can see here how the number of patients who finally received autologous stem cell transplantation was 90% in both arms. It's true that the median number of CD34 positive cells collected was slightly lower in dara-VTD, and more patients require plerixafor, but maybe you understand that 6 million is CD34 cells enough in order to do at least 2 autologous stem cell transplantation. When we evaluated the role of dara-VTD across a different subgroup of patients, we can see how the benefit is observed in patients with ISS3 as well as in patients with high-risk cytogenetic abnormalities. This is derived from the fact that patients with these high-risk features do respond very well to dara-VTD, and indeed they are able to achieve also minimal residual disease negative, and we know that this is extremely important because the achievement of MRD negativity is going to be able to overcome the poor prognosis of the presence of ISS3 or high-risk cytogenetic abnormalities. So with this data, you know that dara-VTD is a standard of care that we can utilize in the newly diagnosed myeloma patients transplant eligible. But it's true that we have to move towards the use also of bortezomib, lenalidomide, and dexamethasone. And you know that VRD is a standard of care, and the next step is to add daratumumab to bortezomib, lenalidomide, and dexamethasone. And Dara VRD has been evaluated in the Griffin study. I thought that I had here the slides. I think that this is the way in which we are going to move forward. Dara VRD evaluated in the phase 2 Griffin study showed also a significant benefit in terms of complete response rate, in terms of minimal residual disease negativity rate, and although this is a phase 2 randomized study, and the trial was not powered in order to see differences in progression-free survival, there is a significant benefit for Dara VRD in terms of progression-free survival. This is the reason why in many centers, in many countries, we moved from Dara VTD to Dara VRD, because we are going to assume that the magnitude of the benefit when we add daratumumab to VRD is going to be comparable to that observed in Dara VTD, and the toxicity profile is going to be better, especially because we are not going to see peripheral neuropathy. In addition, at last ASH 2022 meeting, we had the opportunity to see also how patients treated with Dara VRD achieving minimal residual disease negative and sustained over time resulted into, again, flat progression-free survival curves. And in terms of different risk subgroup of patients, from my point of view, Dara VRD is very effective in patients with no cytogenetic abnormalities or with just one high-risk cytogenetic abnormalities. And even Dara VRD is able to partially overcome the poor prognosis of the presence of abnormalities in the chromosome 1. And if we move right now to the transplant-ineligible population, VRD is also one of the standard of cares. But the rationale for VRD in this transplant-ineligible population is this SWOG study. And you know that this study was not specifically conducted in the elderly population, and this is a subanalysis presented at ASH 2022. And I would like to remark how when we focus on the 202 patients older than 65 years treated with bortezomib, lenalidomide, and dexamethasone, followed by Lendex, the benefit in progression-free survival in comparison with lenalidomide and dexamethasone, or even the benefit in overall survival, is quite marginal, with a hazard ratio of 0.83 for both time to event data, and most importantly, when we evaluate the safety profile and the treatment discontinuation due to toxicity, 47% of the patients treated with RVD followed by lenalidomide and dexamethasone had to discontinue the treatment. And from my point of view, this is maybe quite toxic, and especially because we have other combinations that can be more effective and safer for the transplant-ineligible population. The first one is Dara VMP, evaluated in the Alcyon study in comparison with VMP. The addition of daratumumab to VMP resulted in a higher overall response rate, as well as complete response rate or better, 46%, and MRD negativity rate, 28%. This translated into a benefit in progression-free survival as well as overall survival. And at ASH 2022, we've seen how the median overall survival for Dara VMP was 83 months, what it is definitely longer than the classical median overall survival we've seen until now in the studies conducted in the transplant-ineligible population, and it was always around 5 years. So this information is relevant. Here we can see again the role of the achievement of minimal residual disease negative as an important surrogate marker, in this case predicting progression-free survival. But at ASH 2022, we've seen how also the achievement of MRD negative is an important surrogate marker predicting also overall survival. And in this slide, we realize that the median progression-free survival for Dara VMP is 37 months, so a bit longer than 3 years. But if you decided to use data VMP and your patient achieved at least complete response, here you can see how the progression-free survival definitely is going to be much more longer than the 36 months reported in the intent to treat patient population. This is clearly related with the quality of life, and in terms of safety profile, the addition of data to VMP did not result in more hematological toxicity, only more infections. But it's true that when we evaluate how many patients had to discontinue because of pneumonia or because of treatment emergent adverse events, the incidence is quite low and comparable in both arms. In the Alison study, you know that after data VMP for the first year, patients received data monotherapy, and data monotherapy is very well tolerated by this population. This is an update of the safety profile, and no new safety data had been reported with a longer follow-up. But maybe you agree with me that the winner in the management of the transplant-ineligible population is DARAL index, the MAIA study, including more than 600 newly diagnosed myeloma patients transplant-ineligible compare Lendex with the DARAL index. And in this study, we've seen an update progression-free survival and overall survival at ASH 2022, and again, in terms of overall response rate, 93%, stringent complete response or complete response rate 51%, MRD negativity rate 32%. This information is not very different to the efficacy data we've just seen for DARA VMP. But in this study, DARA index were given as continuous therapy until progression disease, and this translated into a longer progression-free survival and 62 months of median progression-free survival for a population in which the median age was 72 years. I would say that this is the longest median progression-free survival we've seen in a phase 3 clinical study conducted in this population. And this benefit in progression-free survival translated also into a significant benefit in overall survival, although the median has not been reached yet. A specific subgroup analysis of PFS showed how the superiority of DARAL index is observed or is maintained across the different subgroup of patients, including those patients with high-risk cytogenetic abnormality. But a more detailed analysis based on the cytogenetic information showed us how definitely in patients with just one high-risk cytogenetic abnormalities, the benefit for DARAL index is very evident. Maybe the benefit is not so evident in patients with 2 or more high-risk cytogenetic abnormalities, but in this case, we have to consider that the sample size are rather small, and concerning abnormalities in the chromosome 1, the MAIA study showed how the presence of just gain 1q didn't report a deleterious effect, and the hazard ratio is 0.36, but amplification of 1q can be considered as a high-risk cytogenetic abnormalities, although again the sample size is not very large. But also, you know how from the safety point of view, no new safety data, and only to remark the higher incidence of neutropenia with the DARAL index because the treatment is given as continuous therapy, but again, grade 3-4 infection rate were higher with the DARAL index, but this didn't result in a higher treatment discontinuation rate. Although you know that the elderly population or the transplant-ineligible population do represent actually a very heterogeneous disease, and we can consider as transplant-ineligible these very fit patients and this severely frail population. So we know that we have to move towards a frailty-adapted therapy, because definitely the frailty is impacting in the overall survival with more power than the presence of chromosomal abnormalities or the chronological age. The ideal situation would be to utilize frailty scores there are different possibilities, and one very commonly used right now in the different studies is this simplified frailty scale based on the chronological age, performance status, and comorbidity index. This simplified scale has been evaluated in the Altion and in the Maya study, and for me it's important to see how when we add daratumumab to this standard of care, we are significantly improving and almost overcoming the poor prognosis of the frailty. And here you can see that a VMP resulted in similar outcomes for the fit, intermediate, and frail populations, at least in terms of progression-free survival. And we know the same effect has been observed in the Maya study. And in terms of infections, there are some parameters, some factors that we can consider in order to predict which patients are at higher risk of developing infections. And these are related with the chronological age, high levels of LDH, low levels of albumin, and when patients do present these factors, it would be possible to prescribe some prophylaxis with antibiotics in order to prevent the development of infections. And I would say that this is especially applicable to the elderly population. As I previously told you, the simplified frailty scale evaluated also in the Maya study showed how definitely DARAL index is much more better in the fit population, but when we evaluate the DARAL index in the frail and we evaluate LENDEX in the frail, you can see how there is a big difference, indicating that daratumumab is significantly improving the outcome even in the frail population. So in summary, I would say that for the transplant eligible population, today we are moving towards the quadruplets combinations. Dara-VTD is the standard of care because it is based on the phase 3 randomized study, but we are moving towards the use of Dara-VRD. The phase 2 Griffin study do confirm this superiority, and maybe the phase 3 Perseus study will confirm definitely the superiority of Dara-VRD. And in the transplant ineligible, well, Dara-VMP is one of the choices, but definitely Dara-Lendex is maybe the winner. Let me finish my presentation with just a clinical case. This is a real patient I have in my clinic. This is a 78-year-old. Now he will be almost 82 years and without previous medical history and quite active from the lifestyle point of view. And in 2020, he was diagnosed of multiple myeloma IgA kappa, RISS3, because the patient felt very well. So when the myeloma was diagnosed, he presented anemia, renal impairment, lytic lesions, and even hyperviscosity, requiring plasmapheresis because the M component was around 7 grams per deciliter. This patient presented in addition the translocation 414. In August 2020, at the beginning, we decided to start with bortezomib plus high-dose dexamethasone just in order to try to recover the renal function. The creatinine clearance was around 25 milliliters per minute, and after the first doses of bortezomib plus high-dose dexamethasone, no changes. We decided immediately to add the monoclonal antibody daratumumab IV because in September 2020, there was the route of administration approved in our country, but no changes in the M spike. In October 2020, I decided to add cyclophosphamide in order to try to enhance the activity of this 3-drug-based combination, but after 15 days of treatment, there was not any change. And how to proceed? The situation was a bit challenging because this was an elderly patient, but with a M component of almost 7 grams per deciliter and around 30 milliliters per minute of creatinine clearance. So this stabilization of the disease was not an optimal response for a newly diagnosed myeloma patient. In principle, we had to consider that the patient was refractory to bortezomib, to dexamethasone, to cyclophosphamide, and to daratumumab. Honestly, the patient had not progressed, but the patient didn't respond. So I decided to move to lenalidomide and dexamethasone, and honestly, and based on an empirical approach, I decided to maintain daratumumab. My rationale was after the first 4 doses of dara in combination with Lendex, we will be able to see if there is any response or no response. But surprisingly and in a positive way, after the first cycle, we've seen how the M component rapidly went down to less than 1 gram per deciliter. In addition, the creatinine clearance clearly improved, and indeed the dose of lenalidomide that was adjusted at the beginning to the creatinine clearance was modified, and the patient is now receiving 25 milligrams because the renal function normalized immediately. Indeed, the patient is actually in stringent complete response, minimal residual disease negative, with a treatment actually very well tolerated. So this was in September 2020, and because of the pandemic by COVID-19, our authorities approved us the use of dara subQ, because this was definitely something much more convenient for our patients, and especially because the time of administration significantly reduced from 7 to 3-5 minutes, from 7 hours to 3-5 minutes. So in this patient, we did the switch from dara IV to dara subQ in the cycle 2, and honestly, no problems. The pre-medication was administered at the beginning, no infusion-related reactions, much more convenient, and now the patient is taking the pre-medication at home, and the patient is coming to the hospital just for the subQ administration of daratumumab, because lenalidomide and dexamethasone are of oral administration. I think that, dara plus lenalidomide and dexamethasone is, if feasible, I would say the most effective combination for the transplant ineligible population. And as I previously told you, for the transplant eligible, daratumumab plus VTD, but if it is possible to utilize VRD, I think that we are going to have a better safety profile. And I stop here. Thank you very much for your attention. And if you have any question, it will be a great pleasure for me to discuss or to reply to your questions.
Thank you very much, Dr. Matthews, for your excellent comprehensive talk. And I think we have time for a few questions. Please, if you have any questions.
Thank you, Dr. Matthews. So I will start with a question. You brought a very important concept during the case that you mentioned regarding the using daratumumab beyond progression, or using daratumumab re-challenge the patient after a while with daratumumab. I've noticed that you continued dara and you switched Velcade to lenalidomide, so that you support using daratumumab beyond progression?
In this patient, your question is basically based about the retreatment with anti-CD38 monoclonal antibodies, right?
Yes.
Yeah, so I think that it is, we don't have much more data, but in principle, in this patient, at the moment of the relapse, I would not utilize again an anti-CD38 monoclonal antibody. And the reason is because when we've investigated about the mechanism of resistance to daratumumab, the expression of CD38 on the surface of the plasma cells is going to be present, because what we see at the relapse is a lower expression, but CD38 is expressed. But the problem is the immune system, and the exhaustion of the immune system is one of the mechanisms of resistance to daratumumab. So from my point of view, I would prefer to give something in between, another different line of therapy, in order to restore the immune system, and maybe as part of the third line of therapy, it would be possible to reutilize again an anti-CD38 monoclonal antibody. Again, we don't have much more evidence, but there are some information coming from some real-world experience based on the retreatment with daratumumab or with isatuximab, the other anti-CD38 monoclonal antibody, and in principle, one immediately after the other, the efficacy is not very evident, and I would not recommend it to go immediately to one after the other.
Great, thank you. Question, Dr. Khalid?
Yeah, thank you, Professor. That is very interesting and comprehensive talk. We were earlier, we have a our center, I think, as a person. But we approved the committee approved it for a second line therapy. So it's not approved on the center in the first line because of the cost effective ratio. So the question is not this. My question is regarding transplant. So I'm looking after lymphoma patients, some myeloma patients. But my question regarding the family transplant in high-risk patients. Always there is a discussion and debate. Will we proceed with family transplant? And as you know, there is only transplants in the US and not and some of them are using the time others are not. So my question, in the absence of that first line, would you consider timely transplant for those patients, or just you go with the transplant, and if the patient relapses, you're going to do the second transplant? You got my point? Did you get my question?
Yeah, so I don't know if the chairs can summarize the question because I can't hear you very well.
So my question, it's not approved the first line. I'm going to so my question, will you for those myeloma patients in the condition that we don't have time to run first line? Would you be able to start the transplant for those patients?
Can't hear you. Well, I'm sorry, I don't know if the chairs.
Matthias, yes. Simply, would you do tandem transplant in transplant eligible newly diagnosed myeloma?
I think it will be very important to
have you got the point, Dr. Matthias?
Sorry, can you repeat me the question? Summarize, or I'm sorry.
Sorry for that. So my question, in the absence, if you don't have on hand daratumumab first line, would you recommend tandem transplant for high-risk patients?
Yeah, okay, thank you. And apologies because, well, I was not able to capture your question. I think so. Indeed, the role of the tandem transplant in patients with high-risk cytogenetic abnormalities is derived from the use of conventional combinations, basically non-including the anti-CD38 monoclonal antibodies. So if we utilize bortezomib, lenalidomide, and dexamethasone as induction regime, and the patient do present high-risk cytogenetic abnormalities, and the first autologous stem cell transplantation is effective, my recommendation would be to go to the second transplant. The question mark is if we utilize quadruplet combinations as part of the induction, is there any role for tandem autologous stem cell transplantation? We don't know yet, and there are some trials ongoing. The French group is conducting a phase 3 clinical study in which they are going to evaluate this because they are going to compare single with tandem autologous stem cell transplantation in patients with high risk after induction with KRT plus isatuximab. In the meantime, well, I would say that if you use DARA VRD and the patient do present a high risk cytogenetic abnormalities, I will evaluate carefully the response to the first autologous stem cell transplantation. And if the patient maybe is already in minimal residual disease negative, you can go directly to maintenance therapy, and maybe it is not necessary to go to the second transplant.
Perfect, perfect. I have two questions from the audience. One is the regarding the reports that are emerging around daratumumab and acute leukoencephalopathy. Have you seen these cases, encephalopathy with daratumumab?
Keratopathy?
Encephalopathy.
Encephalopathy? Oh, no, honestly, I've not seen any patient with encephalopathy after treatment with daratumumab. So, honestly, no, I don't know if the person asking the question will have more information about this.
The second question about what regimen you use as a prophylaxis against infection when you use daratumumab?
Yeah, so we utilize always antiviral prophylaxis with acyclovir, and concerning the prophylactic antibiotic, it is only considered in the very elderly patients with a poor nutritional status, frail, with prior history of infections, or with severe hypogammaglobulinemia. And in this case, that this is reduced to no more than 1/3 of our patients, we utilize levofloxacin, but during the first 2-3 months. Once the patient is responding, we consider that the majority of the patients do recover some immunoglobulins, the risk is lower, and we usually stop prophylaxis with antibiotics.
Thank you, thank you. Is there any question, Dr. Marwan?
She's the expert in myeloma, and she's an expert in myeloma, and she has a well-known reputation among us oncologists in Jordan. We really appreciate what you are doing regarding myeloma, and we wish you will be with us hopefully as soon, even sooner than this month in Jordan.
Dr. Matthews, one of our colleagues is inviting you to Jordan. He's not, he doesn't have any question.
Exactly.
But I think we'll conclude our session. Thank you very much, Dr. Matthews. There's no further questions, and by this, I think we'll conclude this day for our meeting. I would like to thank the Jordan Society of Hematology and all audience who kept for this late time. Thank you again, Matthews, and we'll hope to see you again here in Jordan.
Thank you very much. Thank you very much.
Thank you.
تقدر تحكي لهم بكره انه راح يبلش برنامجنا على 1:30 بس. اللي صار فيه موديفيكيشن شوي.
البرنامج بكره ان شاء الله راح يبدا على الساعه 1:30 ان شاء الله.